isolated. This was observed globally. And as in the search for diabetes study in youth, the trajectory is increasing and with time, and was really more observed in certain ethnic groups. So for example, this study, which was done in the United States, they identified the highest prevalence was in African American and in Latin ethnicity. When we speak about children and childhood obesity, it's very important to cite this paper. So we conduct this study, and it is time for an adolescent health surveillance system in Saudi Arabia, finding from Una study. And this study, it was like include all the provinces of Saudi Arabia, and we have more than 12,000 participants, including all the provinces of Saudi Arabia. And from this, we identify 15, almost 16% of estimated population are obese. So this is quite alarming. So as you can see, with time, our children become more obese, and with obesity, they will develop the complication of obesity, which is type 2 diabetes, pre-diabetes, and type 2 diabetes. Very interesting paper published by Dr. Khalid Rabi'an about national surveillance for type 1 and type 2 diabetes and pre-diabetes among children and adolescents. This was population-based study published in 2015. And in this paper, they included 23,000, and we can divide it into two, either subjects who have diabetes and subjects who are not known to have diabetes. And those who are healthy, okay, not known to have any problem before, identify quite good number or proportion of them with type 2 diabetes. So the disease is there. The pre-diabetes stage is there in the community. And if we as healthcare provider did not really pay attention to this problem and go and search for it, we will not find it unless presented late, and which carry a major risk factor for complication. And regarding the risk factor for this study from Dr. Khalid Rabi'an paper, they found that the bigger the child, more than 13 years, associated with 34% increase in the diabetes in univariate analysis. Also, male gender was more dominant than female. This is like not consistent with international figures. And also, they have high cholesterol, high triglyceride, and low HDL. So this is the package which we call metabolic syndrome. So if we don't really look for this as a package and as a problem, and this is a pandemic, probably we will really underestimate the problem. And if you want to read about diabetes in Saudi Arabia, this is a very nice paper published by Dr. Aqil from Qasim University about pediatric diabetes in Saudi Arabia, challenges and potential solution. So diabetes, type 2 diabetes, it comes, but before we have full-blown type 2 diabetes, we will have the state of pre-diabetes. And in the US, the estimated prevalence was 26% among obese children. So if you see obese child with signs of insulin resistance, his chance of being pre-diabetic is 26%. So that 1 in 4, they will be pre-diabetic. So if you don't work in this 1 in 4, like 25% of childhood population, this will progress to pre-diabetes, from pre-diabetes to diabetes. Major risk factor for diabetes is obesity. And as we know in pediatric, we define obesity based on the body mass index. And the major risk factor of type 2 diabetes related to obesity is the presence of abdominal fat and the central obesity. And usually this is have multifactorial. Okay, start from the community to the household to the genetic. So when we plan intervention, we should look to the big picture and put the right context in order to have the effective intervention. As you know, obesity have multiple complications. It can affect renal, endocrine, respiratory, orthopedic, psychological well-being, cardiovascular. So basically, it affects all body system. And this poor child, if we did not tackle him as a whole, as a complete unit and complete comprehensive intervention, probably will not manage to address his needs. So if we just concentrate and look to the A1C and that's it, probably will fail, because A1C is not the only solo marker for success. Patient will have, for example, orthopedic complication. He may have increased non-alcoholic hepatic steatosis. He may have also psychological disturbance from being obese. And also he may have obstructive sleep apnea. So this package, we need to look at as a whole in order to prevent complication. So we see always type 2 is there is a genetic predisposition. And study showed that among monozygotic twins, in which one of them developed type 2 diabetes, the chance for the other one will be 90%. So this is quite interesting. Then if for children or adolescents with type 2 diabetes, 1/2 to 3/4, they will have at least one affected parent, okay? And if both parents have type 2 diabetes, then the chance will be even higher. And there is estimated 20% risk for developing type 2 diabetes by late adulthood for the parent if they only have type 2 diabetes. And this risk will increase to 30%. So we know, we said always to our patient, type 2 is multifactorial, but finding this really make this interesting. And we know, with as I showed you before from the previous slides, that with time, the child will become more obese, and his chance to develop diabetes is become more. He will have insulin resistant. He will have pubertal hormone. He will have hyperinsulinism. Then he will be frank case of type 2 diabetes. So the type 2 diabetes onset, 40% presentation between the age of 10 to 14, and 60% between 15 and 19 years. And insulin sensitivity decreased by approximately 30% during puberty, which is related to search of pubertal hormone, increased growth hormone, and all this antagonize the action of insulin and precipitate insulin resistant. We discussed the gender, and we said, like, our local data suggests male predominant. However, international said maybe it's more common in female. Very important concept when you speak about type 2 diabetes is prenatal exposure. Metabolic syndrome inside during pregnancy, like having IUGR and or gestational diabetes, this will lead to intrauterine fetal programming and predispose them to obesity and metabolic syndrome, as it was proven by long-term cohort studies. Type 2 diabetes in children can present in either one of these four presentation, either asymptomatic, and this happen when you just examine a child and you find he has hyperglycemia and he has ketosis nigricans and his blood sugar reading or A1C is in the diabetic range. Or common presentation, he may present with polyuria, polydipsia, or he may have and weight loss, and this is maybe the start of the decompensation, or may he present with hyperosmolar of diabetic ketoacidosis or hyperosmolar hyperglycemic state. The classic teaching said type 2 diabetes do not have DKA. However, we see it, okay, in certain ethnic like in African American, DKA can like type 2 diabetes can present with DKA in 25%. Okay, and in other communities like in Hispanic, the range from 5 to 12%. And it's always interesting to differentiate between hyperosmolar hyperglycemic state and DKA because the management is different. In hyperosmolar hyperglycemic state, there will be marked hyperglycemia with hyperosmolality and severe dehydration and little or no ketones. And it can be presented in 2% of type 2 diabetes. And this is the opposite of DKA. We know DKA will have metabolic acidosis, they have significant hyperglycemia, and they have ketonuria and ketonemia. Should we screen our community for type 2 diabetes? Okay, so the answer is yes. According to the American Diabetic Association and ISPAD, they recommend overweight or obese, plus one of the following additional risk factor, either type 2 in the first or second degree relative, high risk ethnic group, history of DM or gestational DM on mother during pregnancy, signs of insulin resistance such as acanthosis nigricans. And screening should be started more than 10 years with either hemoglobin A1C fasting, blood glucose, then annually. So if we just sit and get the big picture of our Saudi community, that around 25%, okay, they are type 2 diabetes, 30% they are obese. So we should screen all the community. And yet in our system, we did not really implement screening for school children. And I think this is probably the future step. What we need to do is really to implement annual screening as recommended by American Academy of Pediatrics. Very important to keep this number in your mind when you are encountering a child, the differentiation between pre-diabetes and diabetes. Pre-diabetes, we have A1C between 5.7 and 6.4, fasting blood sugar between 100 to 125, or between 5.6 and 6.9, and oral glucose tolerance test between 114 and 199, and between 7.8 and 11. And to tell you the truth, we rarely do oral glucose tolerance test. Why it is important? I want to stress this point. Why we need to diagnose pre-diabetes? Because this is a golden opportunity to catch the patient and start effective intervention. And of course, you know, the cutoff value for diabetes, A1C more than or equal 6.5, more fasting blood sugar more than 126, and OGTT more than 200. So sometimes the patient will present to you with the clear presentation. He's type 2, he's obese, he has acanthosis nigricans, and so it's easy for you to label him as type 2. And type 1, usually they have different presentation. Usually they are thin, they don't have acanthosis nigricans, they have signs of insulin deficiency, and they have DKA. But sometimes the picture is not clear. So either we saw obese type 1, okay, and we saw non-immune type 1 with our which has the classic presentation type 1, but no negative marker. And so the spectrum is very important. But the good thing is that initiation of the treatment in the decompensation state is the same. So we need to start IV fluid and we start insulin. Then we can think about further classification. And to differentiate between type 1 and type 2, there is certain marker that help you, like we know islet antibody will be positive in type 1, C-peptide will be markedly elevated in type 2, and also family history more common in type 2, and associated autoimmune disease more common in type 1. So what is the goal? The goal for type 2 is, number 1, to achieve and maintain glycemic control, to improve insulin sensitivity and secretion, to identify and treat complication, prevent complication. It's very important to look to the patient, as I mentioned before, as a whole, but not looking only to his blood sugar. We start with non-pharmacological therapy, start with nutritional therapy, improve physical activity, weight management, such as weight reduction, program versus weight maintenance. So in children, we said, okay, because they're a growing population, when they get taller, they will have better body mass BMI. But it's very important to stress about the importance of weight management. Regarding the pharmacological agent, metformin and insulin is the first line therapy for the treatment of type 2 diabetes. And liraglutide and exenatide are approved by FDA as a second line agent. Metformin is very user-friendly. And unfortunately, some physicians are afraid from prescribing metformin, which shouldn't be the case. And it can be really prescribed as a monotherapy if A1C is less than 8.5. Together with insulin is if A1C between 8.5, more than 8.5. And if the patient presents with DKA, you can start with insulin, then later on you add metformin. And it was approved for more than 10 years. And if we have type 2, frank, 8 years, we will use it. Okay? Insulin, as we start with basal insulin, if the patient needs basal bolus insulin, we will use it. New things we start, recently we start to hear about liraglutide, which is glucagon-like peptide receptor agonist. And this drug has FDA approved, like for Victoza, approved for children with type 2 diabetes more than 10 years. And as a treatment for obesity, more than 12 years. It acts centrally and peripherally. It decreases food consumption and increase insulin secretion and decrease glucagon secretion also, and decrease gastric empty. And the evidence was published in New England Journal of Pediatric of Medicine, which showed really effective intervention with liraglutide for in children with type 2 diabetes and in obesity. The last drug category I would like to talk about is a trial of sodium glucose cotransport 2 inhibitor, which is a new drug category. It was now approved for adult and pediatrics, evolving evidence. It has so many good effect, and I think this is a promising therapy. And we have the approval to conduct a randomized control trial about ertugrofloxacin for pediatric population, and the study is ongoing. We're expecting to have the data in 1 year time. I would like also to highlight the Saudi diabetic clinical practice guideline, which was published recently for all our audience. And I have the privilege to work in the pediatric part of this one. And with this, I would like to conclude, and thank you very much.
Thank you, Dr. Mohammed, for this excellent talk. Second speaker is Dr. Adnan Al-Sheikh. He will talk about monogenic diabetes. Professor Adnan, he's a professor of pediatric endocrinology at King Abdulaziz Medical City National Guard Hospital, Jeddah, Associate Dean, College of Science and Health Profession, King Saud bin Abdulaziz University for Health Science. Professor Adnan, the floor is yours.
Assalamu alaikum wa rahmatullah. Can you hear me? Is it clear? Is the voice clear?
Yes, it is clear.
Great, great. I would like to thank Dr. Mohammed Al-Mutlaq for the invitation, for arranging this interesting and important activity. And I'm impressed about the number of attendees that I can see, those who participated. Now I can see that they are more than 860. So I wish all the success for this conference. So my topic or my presentation will be on monogenic diabetes. And this is an outline of what I'm going to talk about. So the forms of monogenic diabetes and physiology of insulin secretion, challenging cases, and those are real cases from my clinic. and clinical aspects of monogenic diabetes, and then we will talk about diagnosis and treatment. So to start with, what are the classification of diabetes? We know the main type of diabetes in children is type 1 diabetes, which is insulin deficiency, or type 2 diabetes, like what Dr. Mohammed Al-Dabi'i just talked about. There is a background of insulin resistance with a progressive insulin deficiency, and gestational diabetes, which develop in the second or third trimester pregnancy, and the specific types due to other causes. And mainly, we will talk about monogenic diabetes. So we know that diabetes, that the classical teaching for diabetes is polygenic. So there is more than one gene, multiple genes will cause diabetes. But is there is one gene cause diabetes? And we call it monogenic forms or monogenic diabetes, and the answer is yes, and I will show you now some of the proven cases. So the forms of monogenic diabetes include MODY, which is maturity onset diabetes of the youth, and neonatal diabetes, and syndromic diabetes, and monogenic autoimmune diabetes, and mitochondrial diabetes. And we can classify their causes into either beta cell dysfunction or insulin receptor defect. And beta cell dysfunction under it, the MODY and the neonatal diabetes and the syndromic diabetes and mitochondrial diabetes and others. And rare, we see the cases of insulin receptor defects. We have one of the examples called Robson-Mendel syndrome, and in National Guard Hospital Jeddah we have two families with that disease, with Robson-Mendel syndrome, and they were confirmed genetically, and they are very difficult to treat. And of course, it is really rare condition in the country. So now let's move to the physiology of insulin secretion. I will show you this slide many times. So this is the beta cell in the islet cells. So I mean in the islet cells. The main glucose is the sensor, actually, is the main regulator of insulin secretion. And the sensor is actually the two things, the glucose transporter 2 and the glucokinase enzyme. So glucose will be uptaken into the islet cells, and then it will be phosphorylated by glucokinase enzyme and then metabolized in the mitochondria to cause high ATP-ADP ratio. That will close the potassium ATP channel. So now it is open, potassium is influxing out. And if it closed, then there is accumulation or increase of the intracellular potassium, and then depolarization of the membrane, of the cell membrane. That will cause influx of calcium and release of insulin granules. And that, of course, need these enzymes. That's also the nuclear transcription factors, which we are going to talk about recently. So this is just another graph show you that these are the transcription factors in the nucleus. You can see that PDX gene is in the center, and it is, if there is any defect in that, it will cause agenesis of the pancreas and development of monogenic diabetes. So again, it shows you that the influx of the uptake of glucose by the glucose transporter 2 and the glucokinase, and then metabolism with in the mitochondria to cause high ATP-ADP ratio, with a closure of the potassium ATP channel and influx of calcium and the release of insulin granules. So now let me move to the third part of the talk, which is the challenging cases. So let me start with case 1. And while I'm presenting the cases, I will show you the types of monogenic diabetes. So this is one of our patients who presented at the age of 8 years with nocturnal enuresis. When we did the blood sugar, fasting was high. As you know, anything more than 126 fasting blood sugar in milligram is abnormal. So this is a high fasting blood sugar, and the postprandial was in the borderline. There was no glucosuria, but the confirmatory test for diabetes was the hemoglobin A1C 6.6 with negative O2 antibodies. So, and this is the family pedigree. So at that time, we said that this is a diabetic child because of the high fasting blood sugar more than once and a high hemoglobin A1C. But we were thinking which type of diabetes. Is he type 1 diabetes, or he is having type 2 diabetes, or he's having Moody, or there's other rare forms of diabetes, or maybe he's taking drugs causing or inducing diabetes like steroids or other medications. So, so we did the genetic testing, and it confirmed that there is a mutation, heterozygous mutation of the glucokinase enzyme, glucokinase gene. And that caused what we call MODY2 diabetes. So just to remind you, where is the glucokinase? So this is the beta cell, and you can see that this is the normal process of insulin secretion. So if there is a mutation of the glucokinase, then the process of insulin secretion will stop here, and then the patient will have insulin deficiency and will develop MODY2. So MODY2 is caused by glucokinase mutation, which is the commonest cause of Moody in children, and it is a common cause of incidental fasting hyperglycemia in young people. And in the UK, we don't have really studies in Saudi Arabia, but in the UK, it causes about 20 to 30% of Moody types. And clinical phenotype is quite distinct. They will have higher threshold for glucose stimulated insulin secretion. So they will present with mild hyperglycemia like our patient presentation, or they will present with gestational diabetes. And they are, and their diabetes or their hyperglycemia is non-progressive, and they don't need any insulin. They do well on diet only. And this is actually one of Dr. Anram al-Mutir patient. You can see that the A1C is maintained on diet only without any insulin treatment. So this is a case of MODY2. Now let's move to the second case, who's Wissam. Wissam is also one of our patients. He presented to us at the age of 6 years with polyuria and polydipsia for a few weeks, and the blood sugar was very high. It was 215 milligram. His systemic review was unremarkable, and there is no history of steroid or any other medication. And previously, he was healthy. There were no consanguinity, but there is a strong family history of type 2 diabetes. And he was not obese. His weight was on the 5th to the 10th centile. There was no evidence of any insulin resistance or acanthosis nigricans, and his clinical exam was unremarkable. So based on his age and the symptoms, polyuria and polydipsia, and he's a thin child, blood sugar was high, we thought that straightforward, this is a type 1 diabetes, and we labeled him as a type 1 diabetes, and we started him on insulin. His blood sugar responded very quickly and almost normalized, and even he developed hypoglycemia on low doses of insulin. So we stopped his insulin treatment, and we went back to his family history and his family pedigree, and we went to the specific ages where the other family members. So this is our patient, and those are his brothers and siblings. His uncles, paternal uncles, developed diabetes as in young age. Maternal uncle, and also a paternal uncle, they developed diabetes in young age, and they were labeled as type 2 diabetes. So we also reviewed this investigation, and it was initially the basic investigation were normal. A1C dropped to 5.8, and we did his insulin level and also his C-peptide level, and his C-peptide is high. It was above the normal range, and islet cells and GAD antibodies were negative. So we started to think of, well, looking to his strong family history of type 2 diabetes, negative islet cell and GAD antibodies, and he required very low doses of insulin, and even we have to stop his insulin. So we suspected Moody based on this finding, and we did the genetic testing, and it confirmed a mutation of a gene called cell gene, CAL gene, and that confirmed the diagnosis of Moody 8. So Wissam is confirmed to be Moody 8 rather than type 1 diabetes. And then after about 2 years, his brother Abdulaziz presented at the age of 4 years, and he developed polyuria polydipsia, and we diagnosed him as diabetes, and we started him initially on insulin before we got even the genetic testing results, and we did the genetic testing, and it confirmed that he has also cell gene mutation, confirmed Moody 8. Now, Abdulaziz behaved differently. After 1 year, he was off insulin, and he was doing very well on diet only, and no evidence of lab evidence of hyperglycemia. So what happened to Moody 8 patient? They have pancreatic exocrine function or insufficiency plus diabetes, because cell gene is really important for the pancreatic exocrine function. Our patient, we screen them for the pancreatic exocrine function, and both of them, they don't have any evidence of that. So you can see that those brothers carrying the same gene mutation, but they were behaving differently. One was on insulin and he needed insulin, and the other is off insulin and on diet only, and both have no evidence until now of exocrine function. With these 3 cases, I will. This is an introduction to the Moody discussion. So what are Moody? They are a heterogeneous group of monogenic disorder. It is an autosomal dominant condition. Their diabetes present before the age of 25 years, and they don't have ketones, and they are usually non-obese. And they have a variable presentation according to the type from mild to severe. Sometimes they will present in adulthood with only during pregnancy, and that is seen in Moody 2 or glucokinase mutation, and they have different progression and severity from slowly progressive to rapidly progressive. And Moody account for 2 to 5% of all cases of diabetes. The characteristic finding that they have negative autoantibodies, islet antibodies. In general, it is negative, and until now, there is more than 15 gene mutation were described to cause Moody. Moody 3 and Moody 2 are the commonest actually causes, and it causes about 80% of cases, followed by Moody 1. And just to show you where is the types of Moody. So this is again the islet cell, and this is the glucokinase. So if there is a mutation of the glucokinase, will cause Moody 2. And if there is a mutation of any of the transcription factors, it will cause either Moody 3 or Moody 1 or Moody 5 or Moody 4 or Moody 8, like our patients. So our patients were Moody 2 the first patient presented, and the two other patients were Moody 8. The commonest cause of, I cannot see this slide. Yeah, so it is a Moody 3 actually is the commonest cause of Moody in adults, and it accounts for about 50% of Moody in the UK. We don't have really a local studies. These individuals are normoglycemic in childhood, but they develop increasing hyperglycemia. And actually, the most important clinical features of Moody that they respond very well to sulfonylurea, which is an oral hypoglycemic agent, and initially, but later on, or eventually, they will need insulin. And then Moody 1, and Moody 1, and then still on Moody 3, patients with Moody 3, they have a very interesting finding. They have actually low renal threshold for glucose. So we use that as a marker for investigating the patient and the family. So if you got a case confirmed to be a Moody 3, then screen the other family by doing urine test for glucosuria, and then if they have a glucosuria, then you can do the genetic testing to confirm. And this is actually a progressive disease, so they develop all the vascular complication associated with diabetes, and they if there's inactivating mutation of the hepatocyte nuclear factor 1 alpha, then it may cause neonatal hyperinsulinemia. And then Moody 1, it accounts for about 10% of Moody in the UK, and they are similar to Moody 3. Patient will have a low, they don't have a low renal threshold, so you cannot use the glucosuria as a marker to screen for the carrier. But interestingly, some patients, they will have macrosomia or neonatal hyperinsulinic hypoglycemia initially. And then Moody 5, those patients, they are not sulfonylurea sensitive, and it's a bad disease with multiple congenital malformation. So if you got a patient with multiple kidney disease or congenital malformation, liver disease, then think of Moody 5. So mutation of the hepatocyte nuclear factor 1 beta cause multiple actually abnormalities in the liver and lungs, and specifically in the kidney. So if you get a patient with monogenic diabetes with multiple congenital malformation, think of Moody 5. So Moody 3 and Moody 1 cause a progressive disease, and Moody 5 is really a bad disease, and Moody 2 is a mild disease. They do very well, and usually they are diagnosed accidentally or when gestational diabetes. So when we should consider Moody diagnosis, if there is a mild fasting hyperglycemia or just isolated glucosuria, or and they are young and lean, non-obese patient with negative autoantibodies, or if there is associated extrapancreatic features, or they presented with gestational diabetes, or they don't have the usual features of type 1 and type 2 diabetes, and it is an autosomal dominant pattern. So how to differentiate? I think Dr. Al-Dubai touched on that. So those patients are young. They have a negative auto antibodies, and they don't have any evidence of insulin resistance or like acanthosis nigricans, and they are not obese, usually like type 1, like type 2 patients who are obese, but they are thin like type 1 patients. And they have very interesting multi-generational affected family pedigrees, suggesting an autosomal dominant pattern. I searched for studies of Moody in the Gulf and in the country, and I didn't find, but I found some studies just to show you what's the percentage of Moody out of of type 1 diabetes. So the studies from Norway showed that it constitutes about 6.5% of about 470 type 1 diabetes. And in Italy also, they found that they constitute about 6.3 of type 1 diabetes. And I did not really find any good studies on Moody in the Saudi or Gulf region. Now let's me move to the fourth case. Now, so this is a 7-year-old boy presented with polyuria and polydipsia and weight loss, and blood sugar was normal with no glucosuria, and so diabetes mellitus was ruled out, but his symptoms persisted. So we did other workup and we found that he got high sodium and diluted urine, and that of course confirmed that he got a central diabetes insipidus. So we started him on DDAVB. But after 3 years, he developed impairment of vision and referred to the ophthalmologist who confirmed optic atrophy. And after about 7 years, he, at the age of actually 11 years, he developed high blood sugar and then he's confirmed to be diabetes. So by now, I think you figure the diagnosis. So what is the diagnosis? So it should be Wolfram syndrome. So what is and that will take me to the second part of my talk, which is syndromic diabetes. So syndromic diabetes, I quoted the possible syndromes which we saw in Saudi Arabia. Wolfram syndrome, I have 2 patients with that, and Wolff-Tralitzen syndrome, which I'm going to touch on it, and Roger syndrome, which is the thiamine responsive megaloblastic anemia. So they present with diabetes, anemia, and deafness, and mitochondrial diabetes. And for the Wolfram, it's an autosomal recessive disorder characterized by this triad, DI and diabetes, mellitus, and optic atrophy, and some of them, they will have deafness. Very rare condition, but because of the consanguinity, we see cases on Saudi Arabia. And the mutation is that by the Wolfram syndrome gene. And then Wolff-Tralitzen syndrome, I borrowed this slide from my friend, Dr. Abdelhadi Habib, who published very good actually studies on neonatal diabetes, and those are one of those patients. They will present with neonatal diabetes and they have a skeletal dysplasia and liver disease. I have actually 2 patients with Wolff-Tralitzen. One of them died, actually two brother and sister, one of them died because of the hepatic failure. So hepatic disease is a very severe condition on those patients. And I think if you see diabetes with a skeletal dysplasia with a liver disease, think of Wolff-Tralitzen and the genetic mutation that they have, EFAC gene mutation. Dr. Abdelhadi Habib published a study on neonatal diabetes, and he found that Wolff-Tralitzen caused by EFAC gene mutation is the commonest neonatal diabetes condition in the Arab population. And I think they have a good number in Medina al-Medina al-Munawwara. So let me move to case number 5. So Malik is presented at the age of 1 month. Currently, he's 14 years old and presented with polyuria and irritability. And he was like settled only with bottle feed and not gaining any weight. At that time, random blood sugar was high, 240, and the A1C was high, 7.2. And the parents were cousins. And there is a positive family history of 2 cousins with diabetes. And actually, they developed neonatal diabetes. So at that time, we thought of monogenic diabetes. We started him on insulin, and we did, of course, the antibodies, and it was negative. And we did the genetic testing by WIS. and it confirmed that he have an insulin gene mutation. Which is
2 minutes, please.
Okay, so I will conclude in 2 or 3 minutes. So we diagnosed him as an insulin gene mutation causing neonatal diabetes, and it's autosomal dominant and with a negative autoantibodies. And actually, it's a large gene, so there is any mutation can cause neonatal diabetes. And this is with an introduction to the neonatal diabetes. It could be transient or permanent, or it could be syndromic. And this is where our patient fit. He has an insulin gene mutation. Actually, the commonest cause of permanent diabetes, neonatal diabetes, is an KCNG and ABCC mutation. So they present with hyperglycemia requiring insulin in the first 6 months of life. It's a heterogeneous disorder with actually a very, very rare incidence, but we see transient cases. And those patients, they don't have abnormality of chromosome 6, and which cause mainly transient diabetes. So the possible causes of permanent neonatal diabetes, either genetic defects causing pancreatic agenesis, or syndromic diabetes, or defects in the potassium ATP channel or insulin gene mutation, like our 2 patients, or a transcription factor. So if there's a mutation of the BDX1 gene, then it causes pancreatic agenesis, and there is about more than 8 genetic causes causing pancreatic agenesis. Now, the syndromic neonatal diabetes, we talked about volcotralism, but also there is something called IBEX gene, and our colleagues in National Guard Hospital, Riyadh, they published really good number of cases with IBEX syndrome, and they present with immunodeficiency and enteropathy with a very poor prognosis, and those patients die in the first, I would say, 10 years of life. Also, there's an IBEX-like syndrome like STAT3 mutation. Potassium ATP channel, just to show you that where is the, so these are the potassium ATP channels. So if there is a mutation of the sulfonylurea receptor gene called ABCC, or of the KER6, which is KCNG 11, then they will develop a neonatal diabetes. Or it could be autoimmune deficiency with diabetes, like this. Now, just a few slides about the treatment, how we treat those patients. It could be diet only, like in MODY 2 or glucokinase MODY, or it could be insulin like MODY 5, or sulfonylurea for MODY 3 or MODY 1, who later will need insulin, or neonatal diabetes. If we confirm potassium ATP channel, it's worth to try sulfonylurea, and you can see that in these studies that they did very well on sulfonylurea. I think I will move to the ISBAD guidelines. So monogenic diabetes is uncommon. It accounts for 1 to 4% of pediatric diabetes. So if you got diabetic patient who is diagnosed in the first 6 months of life, of age, then he should have a genetic testing to confirm which type. How about in the 6 to 12 months of age? If the antibodies is negative, then also do genetic testing. I would say in general, a child who is less than 1 year of age who presented with diabetes, it's recommended to do the genetic testing to confirm the monogenic diabetes. And I will move to the conclusion. So it's really important to identify monogenic form of diabetes. Think of MODY in patient with incidental hyperglycemia or gestational diabetes, or of the parents' history of non-insulin diabetes with an autosomal dominant pattern, or there is glucose intolerance or gestation diabetes. Apparently, type 1 diabetes in children is not always type 1. Think of MODY, think of potassium ATP channels causing neonatal diabetes, or MODY, and do a test for genetic testing by WIS whole exome sequencing, which is getting cheap now, not very expensive, in cases of neonatal diabetes or any patient present, I would say, less than 1 year of age if the antibodies is negative. Now, genetic testing is not cheap. It is expensive, but it is worth it because it's going to affect your management. You are going to shift the patient from insulin to oral hypoglycemic, and it will also affect the genetic counseling, and it will tell you about the natural history and the prognosis of the disease. So it is really expensive, but it's worth to do it. And if mutation the potassium ATP channels or MODY3 or MODY1, then it's worth to try to switch him to oral sulfonylurea. With that, I would like to thank you for your attention.
Thank you, Dr. Adnan, for your excellent talk and sharing with us this nice or interesting cases. Just before going to Dr. Abdul Hadi presentation, just to remind all of you to put your question in the Q&A box. So we'll have our discussion after, inshallah, after this next speaker. So next speaker is Dr. Abdul Hadi Habib. We'll talk about challenging cases in childhood diabetes. Dr. Abdul Hadi he's chairman of pediatric at National Guard, Medina, KSA, and the ASPID Secretary General. He was trained and practiced in the UK for 15 years before moving to Medina in 2007. His main research interest is monogenic diabetes and associate editor for the Journal of Pediatric Genetics. He's a fellow and examiner for the UK Royal College of Pediatrics and Child Health, the convener of the ASPID ESP Endocrine Academy, the coordinator of the ASPID Live webinars. He's also a member at the International Consortium for Neonatal Diabetes and the steering committee of the ASPID ISPAD Diabetes Academy. Dr. Abdul Hadi, welcome.
Can I talk now? This one and this one. Yeah, okay, thank you very much. And thank you, Salman, for the introduction. And I would like also to thank the organizing committee and congratulate them really for organizing this conference and attracting almost 1,000 participants, both online and face-to-face. And I'd like also to thank Dr. Mohammed Al-Mutliq for inviting me and giving me the opportunity to visit Unaizah. It's the first time for me to be here. I was given the task to just cover other different areas of pediatric diabetes. We heard about type 2 diabetes and monogenic diabetes, and I think it is time to share with you some cases, mainly on type 1 diabetes. I'll also touch on secondary diabetes and also monogenic diabetes. So all what I'm going to talk about is real case scenarios and patients I came across from which a lesson has been learned. And as we heard this morning, childhood diabetes is very spectrum condition. The majority of patients will have type 1 diabetes. And recently we started to see patients with type 2 diabetes as well as monogenic diabetes. And I have to say, the picture is very difficult really to differentiate sometimes between type 1 and type 2 diabetes because there are a lot of overlap. We hear about the obesity as a more determining factor of type 2 diabetes. And this is, yes, true, but we shouldn't really forget that there are some patients with monogenic diabetes can present with diabetes and obesity as well. And likewise, type 1 diabetes also can have obesity. So it is not as easy as you might imagine. Now, there is also a group of patients or pediatric patients who develop diabetes secondary to either medications or conditions, clinical conditions. And I think the best example for this is thalassemia, for example, can cause secondary diabetes. And of course, steroid and some chemotherapy can also cause diabetes. Now, I need to remind you that type 1 diabetes is very common in Saudi Arabia. And you can see here in this worldwide picture, the incidence of type 1 diabetes in Saudi Arabia is as high as Northern Europe. And here, Saudi Arabia in the red zone, where the incidence is more than 30 per 100,000 of the children's population. But you have to remember that this data is based on just 2 studies. We don't really have any national registry to be able to conduct a clear-cut data on the incidence of type 1 diabetes in the country. What we have is the 2 studies, one in the Eastern Province, published by Dr. Mohammed Abdul-Jabbar group, which showed incidence of 27.5 per 100,000, and another study from our group, which showed a similar picture, 29 per 100,000. And here I'm talking about incidence of newly diagnosed type 1 diabetes, which is different to the prevalence. We know the diagnosis of type 1 diabetes is very simple. Some of them will present with just clear-cut diabetic ketoacidosis. Some will come under the category of walking winded. And by this, I mean patients who are just slightly symptomatic, polyuria, polydipsy, etc. And they have a random blood glucose for more than 200 milligram per deciliter. So it's not really difficult to make the diagnosis of type 1. Type 2, you have to screen and dig further, but type 1 is very straightforward. They can't hide. Some patients have no symptoms, but you can maybe detect them at A1C of just over 6.5, or they might have a fasting glucose more than 1 to 6 milligram, which is the typical classification or the typical criteria for diagnosing diabetes, both in pediatric and adult. But I have to say, in children, they usually present with DKA, particularly in our country here. Although the diagnosis is very simple, there are some mistakes, and I will take you through maybe 2 cases where a big mistake has been made. The first one is a child who was admitted, or he attended to our hospital, or he went really, or she went really to hospital in a private hospital in Medina with abdominal pain and vomiting. She was dehydrated, she's got tender abdomen, electrolytes were normal, blood glucose was done, and sorry, this is a boy, in fact, and blood glucose was not done for this boy. And the diagnosis of appendicitis was raised based on the fact that he has abdominal pain, tender abdomen, and dehydration. And I think this is something you would expect, really. So he underwent appendectomy, which relieved his abdominal pain. The scar was fine, and everything went very nice, but the child didn't recover. Post-operatively, he continued to be in coma. And at that time, his blood sugar was measured and found to be very high. And the question was raised whether this child developed DKA, where in fact, the child was DKA, not appendicitis. There was no report on the pathology or the appearance of the appendix, but the child was referred to the maternity and children's hospital. Luckily, he recovered. Yes, I mean, he has DKA, and he recovered without any complications. And this is his picture when he, just before discharging from the hospital. So this child was very lucky, but others might really don't recover very well, or at least they will develop a neuro complication. We leave this one aside. This is another girl, and this time it's a similar story, but a completely different picture. And this girl came to one of the private hospitals with tender abdomen. She was given analgesia. She was seen by a general pediatrician who suggested a referral to gastroenterologist. Seen by the gastroenterologist, had endoscopy, or suggested to do endoscopy. The family refused this, and they decided to go to another hospital. Again, continued to have pain and became generally unwell. In that hospital, the blood glucose was measured and was, as you can see, 430 milligram, which is very high. And she also has acidosis. Therefore, she was transferred to the maternity and children's hospital as a DKA. So it is just the opposite of the previous child. When she arrived to the hospital, she was shocked. She had severe abdominal tenderness, and the blood glucose is high, confirming what has been found in the previous hospital. Acidosis, lots of glucose, just 1 plus of ketone, and the impression was DKA. And I think everything here going with the DKA, isn't it? Right. So she was treated with IV fluid. She was given the maintenance plus the deficit and had the usual DKA management, insulin infusion, and was admitted to the PICU for close monitoring. But you have to remember here, the ketone was just 1 plus. 8 hours later, biochemically, she was fine. The pH improved, glucose normalized. And in fact, she started to show some degree of hypoglycemia. But she continued to have pain, and the vomiting got worse. On assessment by the medical team, she found to have rigid, guarding abdomen, and at that point, there was no ketonuria at all. And this raised the question whether this is really a DKA or not. And we know that sometimes, if you have really DKA, it takes time to clear the ketones from the urine. So we called the surgeon, and we know the surgeon are very aggressive. But I think in this case, they really made the right decision. And what they did, they took the child for urgent laparotomy. And as you can see here, she's got dark bowel, twisted. Unfortunately, it was too late because she lost the majority of her bowel, which was taken out. The scar was fine, but the message here, this girl got what we call stress hyperglycemia caused by mid-gut valvulus. And I think the message we have to learn from this case is, yes, DKA can present like appendicitis, but at the same time, some surgical abdomen can present with hyperglycemia. So you really have to be careful. And this was a disaster. The first patient recovered very nicely, was very lucky. This girl missed or lost the majority of her large bowel. It was a sad story. So I think what we need to remember from these two cases, at least, is that DKA can resemble acute illness, example, appendicitis, pneumonia, and bronchiolitis. And it's better to check the blood glucose before diagnosing appendicitis. And you may say this is a basic thing, but these things can happen. I mean, it is, yeah, we all learned in the medical school to do these things, but in real life, sometimes you get overwhelmed with the work and you think you made the diagnosis right, and you end up with a disaster. You also need to remember that the severe sepsis, peritonitis, or convulsion may cause transient hyperglycemia, as we've seen in this child. And these patients, they can have glucosuria and ketonuria, but the degree of ketonuria is usually very low compared to the real diabetic ketoacidosis. Right, we'll leave this one and we'll move to another child. And this is, I would say, is a lucky girl. And this was referred to us from Yamba. I'm sorry if you can take the top bar because it is obstructing some of the slides. I don't know if you can take. Anyway, so this girl was referred from Yamba. She was born at term, normal delivery, normal birth weight. She was discharged home on the second day. She is the second child to consanguineous parents, and they have a first healthy child. At the age of 4 weeks, she developed respiratory distress and poor feeding and was taken to the hospital. They did CBC, and you can see here the hemoglobin was very low. The platelet was also low, but her white cell counts were fine. She underwent further investigations to identify the cause of her anemia. She was given blood transfusion. 2 weeks later, she presented again with vomiting and dehydration and high blood glucose. So it was definitely DKA. Her hemoglobin A1C was 6.9. The parents, rightly so, they said, well, the blood transfusion caused all this problem. And I think they have the right to raise this question. So they requested a second opinion. And this is from their local hospital in Yamba, where that hospital referred her to a higher center in Jeddah. There, they confirmed that she has diabetes. They started her on insulin, but she continued to have a low hemoglobin, so she required another blood transfusion, and she continued to need frequent, regular blood transfusion throughout her first year of life. She also had 2 bone marrow biopsies, but were not really good enough, or they were inconclusive to answer the cause of her diagnosis. The diabetes is not related to anemia or transfusion. That's what the family were told. And they said the only way for her is to continue having a regular blood transfusion until the diagnosis is more clear. And based on this, the family said, okay, because Medina is closer to us, let us go to Medina. At least we will have the regular transfusion in the same way, and it will be shorter distance compared to Jeddah. I met them in the endocrine hematology clinic along with my colleagues, and this is her face, or this is how she looked at that time. She was 13 months. She was pale, she had no jaundice, but she was thriving nicely and she got normal development at that time. There was no concern about the hearing. She has no hepatosplenomegaly, no lymphadenopathy. She was on a good dose of insulin, 1 unit per kg per day, but her hemoglobin A1C was high at 10.2. This is her hemoglobin on the day. It was very low again. Platelet also low. White cell counts normal. The mean corpuscular volume was within the normal range. So the combination of neonatal diabetes, i.e. diabetes presenting in the first 6 months of life, plus anemia raised the possibility of monogenic diabetes. And we heard Adnan talking about monogenic diabetes and how to suspect monogenic diabetes. And in fact, because she has anemia and diabetes, we know that there are some conditions that can, the combination of both, like the thiamine responsive megaloblastic anemia, but this girl has got a normal MCV. The hematologist said, don't bother about that because she had frequent transfusion, then the MCV will not be really reliable. And the parents thought that she listened to them, she can hear them. So we didn't really raise the issue of deafness because it's part of the condition. But anyway, so my question to you, if you can, at least people in the audience here, would you give another blood transfusion to this girl or repeat the blood test or request hearing test, start thiamine or start genetic testing or send for genetic testing? Any thoughts? Genetic testing. Everybody says genetic testing. I'll tell you what we did. You should really correct the hemoglobin because it's very low. So you can give blood transfusion. I don't think there's any harm of this. Hearing test, you can request that because the result of the hearing test, you can get it before the genetic testing. And of course, you can send for genetic testing. You can start thiamine empirically if you want. But so this girl received blood transfusion and her hemoglobin went up to 11. She had hearing test, which confirmed bilateral sensorineural deafness. So we thought we are very close to reaching the diagnosis. And in fact, the diagnosis was confirmed by the genetic testing, which identified a homozygous SLC 19A2 gene mutation confirming this condition. So based on that, we started her, or we add thiamine to her insulin treatment. We also referred her to the ENT who inserted hearing aids. And we explained to the family that you can really have a healthy child using the PGT technology. They were really reluctant, but this is her hemoglobin A1C, and you can see the 18 months after giving the thiamine, the A1C came down nicely until 7. The insulin dose was reduced by 60%, and she had no further blood transfusion until today. She is now 11 years following in my clinic, and she had no further blood transfusion. And I think this is a major achievement. We cured her anemia, but she's on thiamine. If you stop the thiamine, everything will go back. And yes, she's still needing hearing aids, but she was able to develop good speech. And I think this is a good achievement for using the genetic testing or reaching the right diagnosis to guide the best management for the child. The family, as I said, were told you have, there is a chance for your offsprings or your coming pregnancy to have the same condition, yet they went on to have another child, and they know the story, so they requested a routine blood in Yamba at 4 weeks of age, and as you can see here, the hemoglobin A1C was very low. The MCV was a bit high, but it's very difficult. I mean, at this age, 8 weeks, I mean, you can't really, 4 weeks, you can't really read a lot into the MCV normal range. They tend to be high anyway. But this girl's got low hemoglobin, low platelet, and her blood glucose was also high. So they rang me. I said, okay, let us start some thiamine as well. Luckily, she managed to be off insulin. We kept her off insulin, just the thiamine alone. She had normal platelet and hemoglobin. She's 6 years now, and she's fine. She's got normal A1C. This is her latest hemoglobin A1C on thiamine alone. And she had normal hearing and speech. Thanks for starting the thiamine early. And she's doing very well at school. Just started the school last year, and she's doing very well. So I think the message or the benefit of the genetic test on this girl is or this family in general, we helped the first child, we certainly helped the second child, and we selected the right therapy, and we avoided the insulin so far because some of these patients will go on to start needing insulin. This is a very rare condition, and I think Adnan has also mentioned it. It has anemia. It's just a triad of anemia, diabetes, and deafness. It's caused by mutation in this transporter gene. If you measure the thiamine in these patients, it will be normal, but their problem is getting the thiamine inside the cells. And I'll show you the mechanism of that. Usually the anemia improves with the thiamine supplement, but there isn't really enough data at that time on how the thiamine can help these patients or diabetes. And this is right, just to show you just a little bit of pathophysiology here. For a lot of enzymes in the body, and it has to be inside the cells. And there are two mechanisms to get the thiamine inside the cells. At the physiological level, the thiamine get transported inside the cells by two transporter, the thiamine transporter 1 and 2. Thiamine transporter 1 is expressed in all cells, and it is the one defected in this girl. It's encoded by the SLC19A2, and this is what this girl has. The SLC19A3 is like the backup transporter expressed in all cells, just except the bone marrow, the beta cell, and the inner cell. And that explains why, if you have a mutation here, this girl or the patients with this mutation, they can get the thiamine in all cells except these 3 organs. And this explains the symptoms. Now, if you treat them with a normal dose thiamine, they will not respond because this has to be get inside the cells. And that's why you give very high exogenous thiamine, so it can bypass all this and get inside. And this is what happened with this girl. And this really motivated us to look at how the thiamine can help this girl. And we recruited patients, a number of patients, 31 patients from 16 countries, looking into the impact of the thiamine therapy in these patients. And as you can see here, as far as the diabetes is concerned, the majority of them has improvement in their hemoglobin A1C. 4 of them became off insulin, and I think it depends on the stage or the age of starting the thiamine in these patients. The anemia resolved, but the deafness persisted in these patients. Do we have time for another quick case? Well, I mean, this is, yeah, okay, let me, this is a 5-year-old boy who presented to us around the time when he developed nephrotic syndrome. He was on prednisolone, and 5 weeks after starting the prednisolone, he started to have secondary nocturnal enuresis, a random glucose 21 millimole, A1C high, no doubt he has diabetes, started on insulin, autoantibody was not done at the diagnosis, and I told the mother, this is just a secondary diabetes due to the prednisolone. And I think most of you will agree with this, yeah? However, 6 months after being off prednisolone, he continued to need insulin. We said, okay, just wait for another few months. 4 years later, and he's still needing insulin. So this child is still needing very high insulin. In fact, he had 2 admissions with DKA, hemoglobin A1C on the high side. So he recovered from the nephrotic syndrome, and he's off steroid for nearly 4 years, but still has the diabetes. So the combination of type 1, I think this child has got type 1 diabetes. And it is just a coincidence that they both happened around the same time, and they're both autoimmune conditions, and this can happen. And they might have a common environmental factor. And I think the message I would like you to remember is if you have a child on steroid and develop diabetes, it's not always secondary diabetes. You have to have an open mind that this patient, particularly if you got an autoimmune condition like this one, it just may be a coincidence. And try, when you talk to the family, prepare them that yes, the most likely it's going to be type 1 secondary diabetes, but some patients can really continue to be type 1, proper type 1 diabetes. And I think there is no time to for these cases, and I think they are similar to the ones Adnan mentioned. Just one thing, I mean, we're talking about MODY. There are now 14 different MODY subtypes. And I think, as you can see here, it's very important to diagnose them because the management is different. Some of these patients do not need treatment at all. Others can be best managed on sulfonylurea, and the remaining can be on insulin. So in conclusion, So DKA may resemble pneumonia or bronchiolitis, and I showed you example of a child an older child with DKA tend to be peritonitis and vice versa. And bronchiolitis also can cause pneumonia, can cause diabetic ketoacidosis. It's better to check blood glucose before diagnosing appendicitis. And as already I said, severe sepsis and prolonged convulsion can cause transient glucosuria and ketonuria. Diabetes with any extra pancreatic features justifies genetic testing, point toward monogenic diabetes, and always keep an open mind to revise your diagnosis. Don't really stick to one thing. And with this, I leave you, and thank you very much.
Okay, thank you, Dr. Abd Hadi, for sharing, I would say, lucky and unlucky some cases. Now the floor is open for the question. Any question inside? Dr. Nawaf, he was having one question.
Assalamu alaikum. I'm Dr. Najib. I have a question to Dr. Abdul Hadi. Regarding presentation of DKA, a patient usually presents with recurrent vomiting, hyperventilation, dehydration. But why develop severe abdominal pain? Is there any mechanism for this? Severe abdominal pain, abdominal pain.
Abdominal pain. Well, there are different mechanisms for that. Hypovolemia can cause pain. And localized hypovolemia, intestinal hypovolemia can lead to pain. Ischemia can lead to pain. These are the two possible reasons for abdominal pain in DKA.
I would like to ask one question to Dr. Mohammed. Dr. Mohammed, thank you for the very nice presentation regarding type 2 diabetes in children. Mostly we are dealing with type 1 diabetic, and most of them, they have obesity. What after your presentation, what I learned that any child who has HbA1c less than 8.5, we should give a trial of oral hypoglycemic. Do you have any study or there are any guidelines, any of these children coming, we should give a trial?
Thank you very much. So the approach for obese type 1 diabetic children versus type 2 diabetes who's presenting with just type 2 diabetes is quite the goals of management is the same. Okay, first we need to resume euglycemic state, either by if the patient is presenting with the decompensation with high hemoglobin A1C, you need to start him in insulin. Then if the A1C is low and he is showing manifestation of type 2 diabetes, you start him in metformin. Always consider lifestyle modification whenever you are seeing obese child presenting with diabetes. So again, we start with the type 1 with the lifestyle modification and healthy lifestyle. Start with if he's fitting the phenotype type 2 diabetes, we send for we start metformin. If you are in doubt, you can see the GAD antibody, and if it is positive, this is hinting toward type 1. Does metformin help in obese type 1? Yeah, there is a meta-analysis published from Dr. Reem Al Khalifa from KKUH in Riyadh, and it showed there is good evidence, especially from weight perspective, to start metformin in obese type 1 diabetic. I hope this answers your question.
Assalamu alaikum, Dr. Adnan. Thank you for your nice presentation. I am Dr. Nawaf from Diabetic Center, King Saud Hospital, Unaizah. I am asking about this different type of MODY. In the future, these types can be developed to type 1. I mean, they will need in the later on insulin, or will continue as they are using?
Thank you for the question. I wish you the best in working in Diabetes Center in Unaizah. Those patients, as we mentioned in the beginning, that they have actually beta cell dysfunction. I mean, MODY patient, they have a beta cell dysfunction. So they have decreased insulin secretion. Definitely, insulin will treat them. One will help them. But do you start as a treatment for life for them? This is why we are saying go better with genetic testing, because glucokinase can do very well, the MODY 2, they can do very well actually on diet only. And also those patients, because of the mild hyperglycemia and late presentation, they could be labeled as type 2 diabetes. So maybe some people will put them on oral hypoglycemic, and we know that it will not really work, and they will just have a side effect of it without. And I think it's definitely the commonest two causes or three causes of them, like MODY 3 and MODY 1 and MODY 5, they need insulin, I would say that. But it depends on the type. So I think I would go with genetic testing, and then according to the results, I will start the treatment. Initially, they will, we label them initially as possibly type 1. The default diagnosis for pediatric diabetes is type 1, especially they are not obese. So we start them, also the cases I presented, we start them in insulin, and then we, of course, modify the treatment according to the genetic testing results. We are doing a shared project between National Guard Hospital, Jeddah and Riyadh, looking at the monogenic diabetes. So we collected the data, and we will publish our results, inshallah, soon in 6 months. As I mentioned, we really don't have a good result, good studies looking at that, at the types and how common. Most of the studies come from abroad, from the UK and Italy and other countries, but not from the Gulf. So the short answer, yes, we would start them on insulin until we get the results, and then we modify our treatment according to the genetic testing results.
Thank you. Shukran.
Thank you. We have one question, the same maybe, or near to your question. Is it recommended to do genetic testing for all diagnostic cases for diabetes, Dr. Adnan, or if we have index case is enough for that?
If is it so if you got a patient who is diagnosed and now his brother has the same disease, or he got the same symptoms of diabetes, most likely he will have the same condition. But I think it's worth to do the genetic testing because they behave differently. Remember, these are an autosomal dominant condition, so they behave differently. You will find that this patient will have no insulin, the other will have insulin, then you'll get confused. Maybe he's type 1, because we know type 1 is not rare in the country, in Saudi Arabia. So I think it is worth, especially it's worth to do the genetic testing, especially we have a lot of consanguinity, and we have also type 1 diabetes is common in the community. We are actually the 5th country to have diabetes sort of prevalence. Now, so this is if an index case diagnosed. If there is no index case and this is the first patient, I think it's really very important to do the genetic testing, not in all type 1 diabetes, but as I mentioned in my talk, if you got really suspected, if you suspect MODY, let's say the pedigree suggestive of an autosomal dominant pattern, or if he's not behaving typically like type 1 or type 2, or if the antibodies is negative, or definitely if the presentation less than 1 year of age. So a type 1 diabetes presented less than 1 year of age, I think it is worth to do the genetic testing.
Okay. We have one question also, Dr. Adnan. Can we see MODY in adults? I think you answered that in the lecture, but you can comment. And what is the maximum age can the MODY presented?
The second part of the question, they usually present before 25 years of age. So if you got a presentation, let's say more than 25, more than 30 years of age, this is unlikely to be MODY. And of course, yeah, a lot of actually type Moody type 2, they present actually in adolescent or in adulthood. This is why it's actually described in the UK that it causes about 20 to 30% of Moody cases. And I think yes, gestational diabetes now, if they suspected, they screen for Moody. Even in our country. So if you got a pedigree suggestive and then a patient developed mild hyperglycemia or gestational diabetes, then they screen for that by the genetic testing.
Sure.
Yeah, just a comment. Modi, patient will not come to you to say we are Modi. I mean, they can be diagnosed at any age because they can be misdiagnosed as type 1 or type 2 diabetes. So I think this is just to add to what Adnan just said.
Okay, thank you, Dr. Abdelhadi. Also, a question for you, Dr. Abdelhadi. You said regarding the hyperglycemia related to stress, usually it will last for a few hours and maybe a few days. So hemoglobin A1C, it will be normal at this patient. So it will be.
Yes, I didn't mention that. I mean, because this girl, the one I presented, has got normal hemoglobin A1C and was asymptomatic before the presentation. And this is what really raised the possibility of non-diabetes, or was against the development of diabetes.
So thank you very much. I'd like to add one point regarding hemoglobin A1C measurement in such cases. When, for example, patient presents with abdominal pain and the picture is not clear. The problem is with hemoglobin A1C, it is not like you need long time to get the result. And implementation of point of care A1C machine is not widely available in all hospitals. So maybe this is an call to implement and use A1C, especially point of care A1C in the emergency room department, in the emergency room, to prevent such catastrophic complication.
Okay, any further question? We have one question here. What is the percentage of retinopathy in children with type 2 diabetes, Dr. Muhammad, if you have, and as compared with adult?
This is a very good question. Regarding the screening, as you know, children with type 2 diabetes, they are growing population, okay? And usually present when there is evidence of insulin resistant, when there is time of puberty. So we rarely, really, to tell you the truth, see retinopathy of type 2 diabetes in children. However, having said that, we still have to screen them as per recommendation, like 5 years after diagnosis, or when they into the puberty, and then in annual basis.
I think we are now off question. Any question? Last question here.
I have one question regarding Modi diagnosis. If we check C-peptide, all Modi will be C-peptide will be high or low, or it will be vary according to the Modi type.
Thank you for the question. We do actually see peptide, and if you did not even start an insulin, we can do also fasting insulin and check the results. I did not find it really helpful in my patient, but if it is significantly low, then it suggests a significant insulin deficiency. We know that in all Modi, actually, they have a beta cell dysfunction and they have some degree of insulin deficiency. So it does not really help you. And two brothers, I presented the two cases. We did, when we found that there is no requirement of insulin, or their insulin doses is very, very low, we measured their C-peptide and we found it even to the higher side. So that That's why we thought one of the reasons for us to think of Moody. So I think it's worth to do it. C-peptide is not very expensive, and it will give you a clue. And if you do it with insulin, if you did not, with insulin level, if you did not start the patient on insulin. And I hope that answer your question. But you will really, the definitive diagnosis is actually genetic testing. Now, I'm sure Dr. Dabei mentioned that one of the diagnostic features in type 2 diabetes, you will find their insulin level in the higher side and their C-peptide on the higher side. For that will maybe give you a clue that this is maybe type 2 rather than type 1, and possibly Moody if there is other features.
Okay, Dr. Mohammed, again, question for you regarding retinopathy. Are there any study in reversing the retinopathy findings in diabetic patient? If patient already developed retinopathy, any reversing study?
As I told you, retinopathy is rare in pediatric population. So I'm not aware about, like especially in pediatric type 2 diabetes.
Thank you. Dr. Adnan, again, we have, I think, repeated question. It's up to you if you want to answer. When we should suspect or to do test for Moody? So it's up to you if you want to.
Yeah, yeah. Thank you for the question. I think it is important, as also Abdelhadi mentioned, a patient will be misdiagnosed as Moody, as type 1 or type 2 diabetes, because this is the default diagnosis. And if you suspected Moody, then you will do the genetic testing. Why we suspect Moody, I will just summarize it in few points. If you got a patient who is not behaving like type 1 or type 2 diabetes, and if you got a patient with a strong family history, following diabetes affecting many generation or multiple generation in an autosomal dominant pattern, and or if there is an diabetes presented in young, let's say less than 1 year of age, or if the antibodies is negative. I mean, if you suspected type 1 diabetes and you did the auto antibodies, islet cell antibodies, or GAD antibodies, and it is negative, then it could be Moody. But look at your patient, look at the whole picture. Thank you.
Okay, thank you, both, all of you, Dr. Adnan, Dr. Mohammed, and Dr. Abdelhadi. Now we have our break. So we have change in
the fourth session, inshallah, it will be at 1 p.m. الآن بحضور اللي هو نائب مدير المستشفى الأستاذ نواف العتيبي، نتشرف بتكريم الجهات المشاركة والمحاضرين، الدكتور محمد المطلق مدير المركز. دكتور عبد الهادي حبيب. دكتور محمد الضبيعي. الآن الشريك الرسمي اللي هو جمعية سكر. والآن الغرفة التجارية مشكورة بالاستضافة لهذا المؤتمر.
Now we'll see inshallah our break, start our break. We'll see you inshallah at 1 o'clock.
السلام عليكم. أبو عزام، كيف أحوالك؟
هلا والله، كيفك؟
الحمد لله، كيف أمورك؟
والله تمام، شو أخبارك أنت؟
محاضرتي الأولى صح؟
أنا؟ لا، الثانية.
أنت الثانية، أوكي. أنا الأولى صح؟
لا، كنا لايف. أقول لك لايف. أنا لكن سوالف تراها لايف ولا لا؟
لا. ها؟
الحلقة.
Are we live؟ لا.
We will start سوني لايف.
طيب محاضرتي الأولى صح؟
بس منورين، هي الأولى.
أوكي خلاص.
أنت أنا بعدك محمد، ها؟
خلاص.
ما سمعت صوت.
سلطان، أنا
سلطان.
السلام عليكم.
عليكم السلام.
نعم، معكم
المحاضرة كم؟ نص ساعة؟
25 minutes.
25 minutes، أوكي.
أنا بعدك محمد على طول، ها؟ سلطان، أنا بعد محمد على طول. 25 صح؟ 21.
نعم. So we'll start our last session today. The first speaker is Dr. Mohammed Al-Mihdil. Dr. Mohammed is the consultant in endocrinology and diabetes and islet cell transplantation in King Fahd Medical City in Riyadh. He's the chairperson for diabetes department, King Fahd Medical City. He is diabetes fellowship program director. He's the diabetes fellowship program director in King Fahd Medical City in Riyadh, and he's clinical associate professor, University of British Columbia, Vancouver, Canada. Dr. Mohammed is going to talk to us in the next 25 minutes about beta and islet cell replacement for treatment of type 1 diabetes. So welcome, Dr. Mohammed, and the floor is yours.
Thank you very much for the nice introduction, and thank you for the organizing committee, particularly Dr. Sultan Al-Fahedi, for inviting me to give this lecture. I have no disclosure to this presentation. These are the outlines for my lecture. So we will start with the study case, then introducing the topic, then I'll talk about the peer replacement therapy for diabetes. Then we will end up by reviewing our case and take summary and conclusions. I hope this will be covered in the next 25 minutes. So our case is a 48-year-old woman who has type 1 diabetes since the age of 3 years. She was on sensor-augmented therapy when I saw her, with total daily dose around 30 to 35 units. Diabetes is complication by retinopathy, neuropathy, microalbuminuria, and CKD with eGFR of around 55. She has a significant history of recurrent hypoglycemia, unawareness, and severe hypoglycemia. This is the islet, and we can see here this in this pathology slide, the islets of Langerhans and the exocrine part of the pancreas. We know the endocrine part or the islet cell constitute only very small volume of the whole pancreas, around 2%, and the islet is composed of mainly different cells. The most prominent one is beta cells, which secrete insulin, followed by the alpha cells, which secrete glucagon, delta cells, which secrete somatostatin, and PP cells, which secrete pancreatic polypeptide. We all know the DCC trial, which compared conventional treatment at that time with the intensive treatment, and they achieved the A1C around 7 at the end of the study, and that was associated with a significant reduction in microvascular complication of diabetes. However, this reduction in microvascular complication was at the expense of increased incidence of hypoglycemia, and there was also incidence of severe hypoglycemia, which can be associated with cognitive dysfunction, loss of consciousness, seizure, and death. Additionally, we know from the EDIC trial, which is the continuation of DCC trial, that the consistency or the good control which was reached at the end of the DCC trial was not sustained. So at the end of DCC trial, all the groups were offered intensive treatment, but as you can see, the final A1C was around 8% for all the groups. This is another graph from the type 1 diabetes exchange group in North America, and you can see the A1C result based on age, and you see most of the people did not reach the target A1C, less than 7%. And you can see here in the adolescent group, the A1C was significantly higher than in the other ages. And you're talking about here good diabetes center in North America, most of them like tertiary care hospitals. And I'm sure the reality is maybe much worse than this. So that's the limitation of the insulin injections and the incidence of hypoglycemia and not sustainable control. Let the people think of other ways to manage type 1 diabetes. So that's the interest in pancreas and eye transplant growed up. Also stem cell therapy, immunotherapy, and gene therapy for type 1 diabetes. The pancreas transplant was first done in Minnesota in 1966. And if you see the outcome here of the pancreas transplant, you can see the most good or the much better control was reached in the simultaneous pancreas and kidney transplantation, followed by pancreas after kidney, and pancreas transplant alone. And I want to concentrate on the pancreas transplant alone here. And you can see the insulin freedom at 1 year was 78%. And we'll try to compare, and 5 years was 54%. And we'll compare this to the other treatment when we discuss them. So what are the challenges or limitations for the pancreas transplant? Number one, the organ supply is limited. There is a significant surgical morbidity because this is a very complicated procedure, and the patient has to take long-term immune suppression with all the side effects associated with the immune suppressive medications. So the islet transplant or the islets were discovered in 1869 by Paul Langerhans when he was a medical student, and since that time the interest increase in trying islet transplantation for treatment of type 1 diabetes. In 1893, William used minced sheep pancreas and extract of pancreas for oral and subcutaneous therapy. Of course, that failed. The discovery of insulin in 1921 reduced the interest in beta replacement therapy or the islet replacement in general. And but until 1972, when Ballinger and Lacey proved that islet transplantation can reverse chemically induced diabetes in rodents. Then studies or trials increase all over the time, but unfortunately they were not successful. Until 2000, when a group of Edmonton published this article in the New England Journal of Medicine, and they reported 7 patients with type 1 diabetes who achieved insulin freedom using a glucocorticoid-free immunosuppressive regimen after islet transplantation. After that, the islet transplantation is spread all over the world, and the islet preparation and isolation and transplant increase all over the time. The procedure itself is not very complicated. So it starts with a procurement of a healthy pancreas from a cadaveric donor or branded donor, followed by cannulation of the pancreas or the pancreatic duct and injection of collagenase, which dissolve and separate the exocrine part from the islet. The islet then isolated in Ricordi chamber using a density gradient centrifugation. Then the final product is stained and assessed for purity and viability before transferring this product to the angiography suite for islet transplantation. In the angiography suite, the interventional radiologist catheterized the portal vein percutaneously. Then the islet preparation is infused in the portal vein. After the infusion in the portal vein, the islet itself gets stuck in the liver, then start to establish blood supply and secrete insulin. So what is the prevalence of insulin freedom after islet transplant? These are the original trials from the islet transplant consortium or ICTR. And you can see at 1 year, 50% were insulin free, and this insulin freedom goes down by 5 years around 20 to 25%. However, the insulin dose was really reduced much, and you can see the average insulin dose units per day, which are around 10 units per day. You can see here the Edmonton group and insulin freedom, which goes down over time. However, they tried to, this is the original one, then they tried to modify their insulin, their immune suppressive regimen, and they reach a much better result. And the insulin freedom was over 60% in 4 to 5 years. This is from our center in Vancouver, and you can see our insulin freedom rate was around 60% at 5 years. This is more recent trial, which compared pancreas transplant alone versus islet transplant alone. And you can see the result is much better than the previous report, and the insulin freedom is over 60% in like 5 to 7 years. And there was no difference between the islet transplant alone versus the pancreas transplant alone. You can see here the fasting C-peptide, which is detectable in mostly all patients after the islet transplantation. And this is from Vancouver group. What about the absence of severe hypoglycemia? And you can see this is an orange color, is the episode of severe hypoglycemia, and it was much reduced after the transplant, and the rate was really low all over the years. Remember, those patients, they are transplanted because they have hypoglycemia awareness and severe hypoglycemia. So this is a very significant thing for them to reduce the severe hypoglycemia episode to this extent. Quality of life was affected significantly. All subjects with residual islet function were completely protected from severe hypoglycemia episodes. Patients were insulin-free or on much smaller dose of insulin. Who should get the islet transplantation? There is no brainer that anyone with kidney transplantation, they can get an islet because they are already on immune suppressive medication and they can benefit from the islet transplantation. Patient with unstable blood sugar or what we call brittle diabetes, severe, especially if there is a history of hypoglycemia unawareness and severe hypoglycemia episodes, and some clinical trials, particularly in Vancouver, addressing the impact of islet transplant on complication of diabetes. Islet transplant now is a standard care procedure in many countries, including Canada, United Kingdom, Sweden, Switzerland, France, and Italy. And it is not still a standard of care in United States because the insurance company is refusing to pay for it. What are the challenges and limitation for islet? Again, like the pancreas transplant, the organ supply is very limited, especially with the islet, you need at least 2 to 3 organs to achieve insulin independence. The patient should be also on immunosuppressive medication and with all the side effects associated with that. There is no markers for rejection or early rejection. If the blood sugars start to go high and the C-peptide is going down, it is too late to intervene at that time. So the limited organ supply for the beta replacement therapy increased the interest in trying to get more cell supply from stem cells. So what is the stem cell? It is a single cell that can replicate itself and differentiate into many cell types. How could we use stem cells in medicine? Like, for example, in our case here, the beta cells. So we created beta cells from the stem cells, and the beta or the created beta cells could be used for stem cell-based therapy. They could be also used to study the disease or disease modeling, type 1 diabetes in this case. They could also use for drug screening and development for type 1 diabetes. And they can be also used in gene editing to try to treat type 1 diabetes by genetic therapy. So to understand the background of the embryonic stem cells and the other stem cells, I will leave you with this short video to understand the origin of the stem cells.
How does a human embryo form? First, an unfertilized egg travels from the ovary to the uterus through the fallopian tubes. Multiple sperm traveling through the tubes will try to fertilize the egg. Once one of the sperm is successful, development begins. The fertilized egg divides into multiple cells on its way to the uterus. After about 5 days, it forms a structure called a blastocyst. The cells inside the blastocyst, known as the inner cell mass, will eventually develop into the embryo. The outer cells of the blastocyst will develop into the embryo's placenta and other supporting tissues. Pregnancy begins when the blastocyst attaches to the wall of the uterus. The inner cell mass forms a disc, and the cells in the disc begin a process called gastrulation. First, some cells move inward, forming a groove on one side of the disc. This groove will determine the embryo's right and left body symmetry as it develops. As cells move inward along the groove, they organize themselves into 3 layers: the ectoderm, mesoderm, and endoderm. These 3 layers, called the germ layers, will develop into different parts of the embryo. As development proceeds, the cells continue to move, divide, and make new structures. About 8 weeks after fertilization, most of the embryo's key body parts and organs will have formed.
Here we're going to go through quickly the early stages of development again. And then we're going to get to this stage when the germ layers are set aside. The 3 germ layers, the ectoderm, mesoderm, and endoderm. So here you'll see then that the inner cell mass gives rise to the entire adult animal, in this case, a human. The same process would occur in a mouse, as we'll see a bit later. If we now look at the embryo after the 3 germ layers have formed, this video will highlight what comes from the blue germ layer, the ectoderm. You'll see that it makes the nervous system, including the brain and the skin. The middle part, the mesoderm, green here, gives rise to the muscle, including the kidneys, the heart, and the endoderm gives rise to the whole gut tube. There you see the lung, the liver, the intestine. And to give one more detailed example of this, let's think about the development of the endoderm. And in this case, the formation of the pancreas. So there's the pancreatic bud, which comes out of the endodermal derivative.
Okay, so these are the embryonic development, and that was the background of the embryonic stem cells. So, but there are other types of stem cells, which we will talk about, like induced pluripotent stem cells, adult stem cells, and cord blood stem cells. As you saw in the video, so the inner cell mass will be harvested from the embryo, then the embryonic stem cells will be cultured in outside in a dish. So this process will involve killing the embryo. That's why there is an ethical issue about the embryonic stem cells, and we will talk about that later. Because of the ethical issues with the embryonic stem cells, scientists thought of other methods of doing stem cells. So they come up with the process of induced pluripotent stem cells. So they are taken from any somatic cells, and through special promoters, they can reverse the somatic cell to a stem cell, which can then differentiate into different cell types, and they call the cells induced pluripotent stem cells. And for this discovery, the Nobel Prize in Physiology and Medicine in 2012 was granted to two scientists who discovered this, John Gurdon and Shinya Yamanaka. The other type of stem cells include adult stem cells, and an example of those are hematopoietic stem cells, skin stem cells, and mesenchymal stem cells, but their potential is limited to only certain cells that they are called multi or unipotent. And the cord blood cells, again, from the name, it is taken from the umbilical cord, and these include the hematopoietic stem cells, which can differentiate into other blood cell types, and mesenchymal stem cells, which can differentiate into some cell types, but not all. So this is the genetic differentiation. So we start with embryonic stem cells or induced pluripotent stem cells, and through special substances and promoters, they are changed to pancreatic endoderm, and finally they are changed or induced to be mature beta cells. What are the challenges? Number one, the ethical issues with the embryonic stem cells, as we talked about. So to get to harvest the inner cell mass, you have to kill the embryo. There is also the issue of the immune attack on the transplanted stem cells. Again, as in the islet transplant, we don't have early marker for rejection. And because they are stem cells, there is a possibility always of tumorigenesis or tumor expression. So to overcome the immune attack to these stem cells, scientists thought of capsulation. So this can be a microcapsulation where you can capsulate the individual cells with alginate, or this can be a encapsulation, which you put them in a special pouch, which is resistant to the immune attack, but allows blood supply and oxygen and nutrients to enter into the pouch. So I worked with Viasite company in Vancouver, and their cell line is embryonic stem cells, where they induce it to be a pancreatic endoderm. Then they put them in a special delivery device, which protect them from the immune attack. Then they transplant them under the skin of the individual. This is their pouch, and you can compare the size to the quarter here. This is a small pouch, and this is the bigger pouch. And the small pouches, they design it so they can explant it later on and study the islets. So phase 1 trial, they put them in a big device which can protect them from the immune attack, but allows blood and the nutrients to enter. However, the body immune system formed a fibrous tissue around the device, and later on that was failed. In phase 2 trial, they made the holes in the device and allow the blood vessels to come inside, but they have to give immune suppressive medication to the patient. And we published some information and regarding the C-peptide positivity in those patients. And this the study is still going on, but the result is really encouraging. Another company from Boston called Vertex, they are also working on stem cell line, and you can see, I think, just in October this year, they reported one patient who had type 1 diabetes, and was his insulin requirement was reduced significantly by 91% after the stem cell transplantation. So back to our case, I know I have 2 minutes. So our patient is type 1 with significant history of hypoglycemia more than 10 times per week, including 1 to 2 times severe episodes weekly, requiring glucagon administration by her husband. And you can see her CGM result here. She received her first islet transplant in 2003, and she required another transplant in 2008 and in 2014. This is to compare her CGM tracing before the transplant and after the transplant. And her A1C was well controlled below 7%. And you can see the first islet transplant was in 2003. Second transplant in 2008, and the third one was in 2014. And she continued to be insulin-free until now with A1C less than 6%. So she has no hypoglycemia since the first transplant. She required insulin briefly before her third transplant, 2008 and 2014, but insulin-free since 2014. So in conclusion, cellular replacement therapy may offer the best approach to achieve physiological glucose control in diabetic patient. The expansion and subsequent differentiation of stem cells, be they of embryonic, fetal, or adult origin, appear to have a considerable potential to overcome the shortage of donor organs. I will end my session here, and I apologize for not staying for the questions at the end of the session. I don't know if we can make the questions now, or maybe we can. You can type your questions, and I will answer it later on through email or through WhatsApp. Thank you very much for your attention.
Thank you very much, Dr. Mohammed, for this nice updated talk, and thanks also for being in time. And we will keep you for 2 minutes only. We'll take 1 or 2 questions before you will leave. We are appreciating your time, and we'll see if there is questions. Any question? So, Dr. Mohammed, what about experience of islet cell transplant here in Saudi Arabia? Do we have any studies, any report cases, any?
Well, we didn't start yet here in Saudi Arabia, but hopefully I have a proposal, and hopefully we'll start soon. Unfortunately, the corona pandemic delayed everything. And when I came, I returned from Canada at the beginning of the pandemic in the end of 2019. But hopefully we have a proposal and we will proceed, inshallah, soon.
Inshallah. So your patient received 3 shots of islet cell transplant, can say. Any limits for number of transplant?
So theoretically, you have no limit, especially if you have a good supply. But to be fair with all the patients, in our center in Vancouver, we limited the infusion to 5 infusions. So after 5, we will offer all the other patients. So it is a priority, of course. If you receive already 5 infusion, you will go at the bottom of the list. if there is any available infusion and there is no other patient to take it, then you might get the sixth infusion. Otherwise, they will go to the. So we are also limited by other factors like the HLA typing. We are limited by the antibodies titer in or PRA we call it. So there are other things which can control who gets the islet infusion.
Okay, thank you very much, Dr. Mohammed. I think there is no more questions. Thank you very much for this.
Thank you very much for for inviting me again, and I wish you all the best.
So our next talk will be with Dr. Saad Al-Zahrani. Dr. Saad is the consultant endocrinologist in King Fahd Medical City, and he's the medical director of Obesity, Endocrine, and Metabolism Center in King Fahd Medical City. Dr. Saad, he will talk to us about the updates in non-insulin treatment of type 2 diabetes. Welcome, Dr. Saad.
Thank you very much, Dr. Zaki. I hope you can hear me well and see my slides.
Yes, your voice is very clear. Make the presentation full screen, please.
Okay, so it's now in full screen, I think. طيب بسم الله والصلاة والسلام على رسول الله. Thank you very much, Dr. Zaki. I would like also to thank Dr. Mohammed Al-Mutlaq, Dr. Sultan for inviting me for this prestigious conference. I'm really glad to be with you. I'm going to speak today about the some updates in non-insulin treatment of type 2 diabetes mellitus. Sorry. So I'm going to talk about some of the latest landmark studies, and I'm also going to talk about some advances in the non-insulin treatment drugs. I will start with this study, which I found very interesting, and I think we have to know it, and we have to act on such patients. This study was just been released called the Today study. It was published in New England Journal of Medicine in last July, and studied the long-term complications in youth onset type 2 diabetes. So it's a multi-centric study. It was done since 2004 to 2011 to evaluate the effect of 1 or 3 treatments on the time of loss of glycemic control. So it's a long-term study looking at the effect of medication, also the rate of complications. The participants were transitioned to metformin with or without insulin, and were enrolled in an observational follow-up study performed from 2011 to 2020. The assessment was done for the nephropathy, hypertension, dyslipidemia, and neuropathy, and also retinopathy was checked for these patients. So there have been 500 participants. The mean age was 26 years, plus minus about 3 years at the time of the analysis. And the mean time since diagnosis was about 13 years. So we do have data about the complications for these patients prospectively about 13 years after the diagnosis. And I remind you that these are patients, young patients with type 2 diabetes. So let's see the rate of complications. Up to 67% of those patients were having hypertension after about 13 years of diagnosis with diabetes. 51% they have dyslipidemia. The rate of nephropathy is up to 55%. More than half of them will have nephropathy. Neuropathy was reported in 32.4%, and retinopathy was reported in 51% of these patients. At least one complication occurred in 60% of the participants. These numbers are really huge and indicates that early onset of diabetes in youth is associated with more complications. And at least 2 complications occurred in to 28%. So 28 or about a quarter or more, a bit more than a quarter of these patients will have at least 2 complications. So what we conclude is that the risk of complication increased steadily over time and affected most participants by the time of young adulthood. Intensive treatment should be provided earlier. And this is the take-home message of this study, that the patients, when they develop diabetes type 2 in young age, you have to treat them aggressively. And the options are really not great, but we were happy that we have liraglutide just being approved for this age group, maybe from 12 years or 10 years of age. So we do have liraglutide for this age group, and which might improve the outcome. In fact, this study didn't recruit any patients using this medication. So this is about the today's study. Then I will go through another important study just being released in the latest or preliminary report released in last ADA in the US, which is the GRADE study. This study have been long been awaited, because it is going to compare 4 of the oral antidiabetic, or 4 of the antidiabetic classes, and look at their effect on diabetes. All studies what we have is either company sponsored and only comparing 1 or 2 medications. For the GRADE study, it compares 4 classes of antidiabetic treatments over, let's say, over 5 years, and it's head-to-head comparison study. So it's a phase 3 trial, included about 5,000 patients in the US with the diabetes duration of less than 10 years. The median was 4.2. The A1C was 6.8 to 8.5%. Those patients were treated with metformin at a dose of at least 500 milligram per day. Then it was increased to 2 grams. So the culprit medication was metformin. Then they have added the other medications. Participants also were randomly assigned to receive either glimepiride, sulfonylurea, the DPP-4 sitagliptin, or the GLP-1 receptor agonist liraglutide, or insulin glargine, in addition to continued treatment with metformin, and the average follow-up was approximately 5 years. Again, I would repeat that the beauty of this study is that it compares 4 classes of diabetes treatment head-to-head. So let's check out the results. First, the proportion of participants who develop A1C level above 7%. So what is the best medication to keep A1C less than 7 among these 4 is glargine, insulin, 67%, while also liraglutide, the Victoza, was associated with 68% chance of being above 7, compared with 77% in sitagliptin and up to 72% in with glimepiride, indicating that treatment failure was higher with sitagliptin and sulfonylurea glimepiride. What about the major adverse cardiovascular events? like heart failure, hospitalization, unstable angina, transient ischemic attack, or revascularization. The best results were with liraglutide. It was associated with significantly lower risk of cardiovascular complications, and the other three classes were almost the same. What about the safety of medications? Rates of serious adverse events were comparable across the 4 groups, ranging from 33% with liraglutide to 37% with glimepiride. So there hasn't been differences in the incidence of serious adverse events. Severe hypoglycemia occurred more commonly among participants treated with glimepiride as expected. There were no significant between group differences in the rate of pancreatitis or pancreatic cancer. So what we can conclude from a great trial, let's focus that this study is a preliminary result and of short duration, only 5 years, and also didn't include a very important class of medication, which is the SGLT2. But it was claimed that the study was started before the introduction of the SGLT2. Insulin and GLP-1 receptor agonists are the best for lowering blood sugar. Microvascular complications were almost the same in all 4 groups. Macrovascular complications were lower with GLP-1 liraglutide. This study is trying to answer a very common question: what is the best treatment after metformin? While again, I have to consider that SGLT2 here were not represented in this study. However, we have seen that the DPP-4 inhibitors have a lower role because the treatment failure is higher compared with the others. The study indicates that GLP-1 receptor agonists might be better choice because of the blood sugar lowering effect, and also for the cardiovascular. Insulin also has provided good results compared with the others. This is again a recently published study. It's called the Emperor-reduced study, which was about the cardiovascular and renal outcomes with empagliflozin in heart failure. So cardiovascular death or hospitalization for heart failure were compared with treatment with empagliflozin, Jardiance compared with the placebo, and as we can see that this study was done in patients with diabetes and also patients with non-diabetes, and found the risk of cardiovascular death or hospitalization was lower in empagliflozin compared with the placebo. Also, over the long run, over 124 weeks, empagliflozin was associated with lower reduction in the EGFR. It means that it is a renal protective treatment. And as you can see in the right side of the slide, there has been let's say a transient reduction in the EGFR, but over the long run, the EGFR was almost constant with the empagliflozin compared with the placebo. The other, again, interesting study has been released, maybe late 2020. This study, this was about the sotagliflozin in patients with diabetes and chronic kidney disease. Sotagliflozin is a SGLT2 inhibitor, SGLT2 and SGLT1 inhibitor, and it has a dual inhibition effect. And again, it was associated with a better primary endpoint, which is number of deaths from cardiovascular disease, hospitalization, and urgent visits for heart failure. Also, this study has included patients with the EGFR from 25 to 60. And we know that sometimes we have been hesitant to use medications, especially the SGLT2 in such a group of patients. But this study shows that this sotagliflozin can be used at this level of EGFR and with good outcomes over a long period of time. Now I will talk about the new agents for the diabetes control. I will talk about the oral semaglutide. Oral semaglutide has been taken in the media these days, and a lot of talks about it. Even the Saudi FDA have released a memo about it. So let's quickly talk about it. So it's the first oral GLP-1 using a SNAC technology. We'll see what's the SNAC technology, and just been approved by Saudi FDA, available in 3 concentrations, 3, 7, and 14. So this is the SNAC technology where the SNAC is attached to the semaglutide molecule, which will help improving the absorption from the intestine. So SNAC increases the intestinal absorption, increases the local pH in the stomach, and provide better solubility for the semaglutide. We know semaglutide is a protein. When we put the SNAC, is going to be absorbed easily from the stomach and intestine. So Pioneer 3 or Pioneer program was designed to evaluate the risk benefits profile of oral semaglutide. We'll go through it quickly. There has been like 19 clinical pharmacology trials, and it has been assessed across the spectrum of type 2 diabetes. It was assessed for monotherapy against placebo. It was assessed also against other oral anti-diabetic agents, and also it was assessed with insulin users, and also assessed in patients with the special population, like those who have cardiovascular problems or renal impairment. And this study was designed to answer many questions. As you can see here, compared with the placebo, oral semaglutide was associated with much better hemoglobin A1C reduction. Also compared with empagliflozin, it is showing better A1C reduction, minus 1.3 compared to minus 0.9. Compared with sitagliptin, again, the same story, almost the same numbers. And against liraglutide, higher doses of liraglutide, semaglutide is almost similar to it. And in the renal patient has been used and showing good reduction of A1C as well. What about the attainment of glycemic target with hemoglobin A1C of less than 7? When it's compared to placebo and monotherapy treatment, it was associated with the 77% chance of being less than 7% with the higher dose of 14 milligram, up to 69 with the median dose, 7 milligram. Compared with empagliflozin, 67% of the patients using oral SEMA were having more chance of being with A1C less than 7, being controlled. The same story against sitagliptin, while against liraglutide, it's almost the same. What about the changes in body weight? Semaglutide was associated with better weight reduction, up to minus 3.7 kilograms compared with the placebo. And weight reduction is comparable with empagliflozin, with the 40 milligram compared with the 25 milligram in the first 26 weeks. Versus sitagliptin, course, semaglutide was better in weight reduction, and versus liraglutide, SEMA is better for weight reduction up to minus 4.4 kilos, compared with 3.1 in patients using 1.8 higher dose of liraglutide. So what we conclude here, we conclude that oral semaglutide is better than other oral treatment for diabetes, for A1C reduction. It's also better than the higher doses of liraglutide. Has no much clinical experience. We have no much clinical experience in the kingdom. Just been approved, but I didn't use it. But it might be a good option for those who don't like the injections. The only problem with it is that it has to be taken early in the morning on empty stomach, and the patient has to take it with 120 ml glass of water, and he should be like should not eat after till 30 minutes after taking the semaglutide. Side effects are as with other GLP-1, nausea and vomiting, but claim that it's improving with time. Let's go to the other treatment in the pipeline, and these treatments are incretin-based treatment, and concentrating on the dual and triple GLP-1, GIP, and glucagon agonists. So it's a group of incretin-based treatment. The glucose-dependent insulinotropic polypeptide, GIP, or the other name is the gastric inhibitory polypeptide, secreted from the K cells in the stomach, and which has an insulin-releasing and extrapancreatic glucoregulatory actions. GLP-1 is secreted by L cells, and simultaneous activation of both is associated with better clinical outcomes. So what we are using now is GLP-1. What has been done by Lilly is that they have got a molecule that works on both GLP-1 and GIP, and they found better clinical outcomes. So this is how it works. These are the GLP-1, GIP, and glucagon receptors. We have the GLP-1 receptor agonists like SEMA, LIRA, working only in one receptor, and the GIP also working on the GIP receptors. Let's check the physiological effect of GIP. They are working on the heart to increase the triglyceride metabolism on the brain. It is neuroprotective, increase neuro generation, and there has been very good studies nowadays about the GIP treatment based on treatment of Alzheimer's disease, and it has many effects beside the work on the pancreas. And this is again, the diagram is showing that if we use dual agonist like tirzepatide, we're going to talk about it now, or triple agonist is much better than a single agonist. So these are the GLP and GIP physiological effects. I will not go through it, but both of them are working to increase the insulin production, and they are working opposite each other in affecting their glucagon. We know that GLP-1 decreases glucagon, while the GIP increases glucagon. But what is good about GIP, when it increases glucagon, it is glucose dependent mechanism. So it will only increase the glucagon when the blood sugar is going down. And this is the beauty about it. So they are working both synergistically to improve the blood sugar. So let's check the tirzepatide. It's a dual GIP and GLP-1. It has a half-life of 5 days. It is taken weekly injection. It is associated with better A1C reduction up to minus 2.4 in the big doses compared with, for example, dulaglutide, Trulicity, 1.5. The A1C reduction is double. And also it's better for weight reduction, minus 2.7 with dulaglutide, minus 11 with tirzepatide. Tirzepatide is expected to get FDA approval in 2022. and is going to be very good competitive for the available GLP-1 agonist. This is a recent study published in New England Journal of Medicine recently, SURPASS-2, comparing the tirzepatide with semaglutide, and guess what? Tirzepatide was much better than semaglutide in weight reduction and hemoglobin A1C reduction. The A1C reduction is up to 2.3, minus 2.3, compared to about minus 1.9 with semaglutide, with again better weight reduction. Now we are in the era of triple GIP, GLP, and glucagon receptor agonist, and there has been a molecule being tested in the preclinical studies and showed much better results for weight and blood sugar control compared with the dual and GLP-1 receptor agonist. So let's conclude here. GLP-1 as a member of incretins have been successfully introduced in the treatment of type 2 diabetes. Dual incretin appear to have stronger glucose and body weight reducing effects compared with GLP-1 receptors. GIP evolves glucose-dependent effect of insulin and glucagon secretion within the Langerhans islets. Tirzepatide is non-balanced GIP GLP-1 receptor agonist, which has shown excellent glucose control, strong weight reduction in obese patients with diabetes. And thank you very much.
Thank you very much, Dr. Saad, for this very concise, informative talk about the new oral treatments for type 2 diabetes. And I think we will leave questions to the end of the session. Just I'm reminding the audience to write questions in the Q&A box if they have any questions or queries. Our next talk will be dyslipidemia in children. And this will be presented by Dr. Muhammad Saleh Al-Dubai, consultant pediatric endocrinologist. So welcome, Dr. Muhammad, again.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah. Salatu ala Rasulullah. Thank you very much again for having me to speak about overview of dyslipidemia in diabetic children. First of all, when I have discussed this topic with Dr. Muhammad Al-Mutlaq, Allah ya'ti al-afiyah, he suggested to be more specific, since we are talking in this is the diabetic week, diabetic month. So we elected to focus about dyslipidemia in diabetic children. I know dyslipidemia in adults is very common and everyone speak about it and very clear guidelines about it, but what about children? So, and is there any evidence that we need really to look for dyslipidemia in children and start early intervention, and this will reflect adult care? We learn from Dr. Saad Zahrani that the screening for youth with type 2 diabetes, really they have alarming number or percentage of dyslipidemia as young adult. So shall we look at this from the beginning in children? And is there any evidence that dyslipidemia will start from childhood and track into adult? So I will focus myself into 3 or 4 main domain: dyslipidemia in general in children, and is it recommended to screen for cholesterol in children? What is the pathophysiology and how we should screen, and what is the evidence, and what's the current guidelines regarding dyslipidemia in children? So longitudinal epidemiological study have demonstrated very clearly that dyslipidemia, obesity, track from pediatric into adults. So normalizing this risk factor from early childhood will decrease the adult risk. So it is very important to embark into keeping healthy, normalizing this risk factor from early on life. It is very evident that atherosclerosis is very longitudinal process. It starts from childhood and may become evident in an early adult. For example, in patients with have high lipid profile, like in heterozygous familial hypercholesterolemia, they will have high cholesterol level and they will have MI at the age of 30 if it is not untreated. And it's dependent on the cholesterol level. If the cholesterol level is very high, then they will have MI or cardiovascular event even before the age of 10 years. So atherosclerosis is a longitudinal process. We really should look early and keep this perspective that what is you're doing now is preventing the harm after 10 years. So this is very important concept. Fatty streak formation occur in human fetal aorta, and I will show you a picture, very nice picture about this. And in Douglas Hart study, fatty streak was present at the age of 3 years. And pathological determinant of atherosclerosis in youth, the age between 15 and 34, found that extended fatty streak and fibrous plaque in the aorta and coronary strongly correlated with elevated cholesterol. And as you can see, this is cholesterol filled foam cell. This was taken from 20-week-old fetus at autopsy. And fatty streak formation occurs in human fetal aorta and is enhanced by maternal hypercholesterolemia. So the atherosclerosis is longitudinal process. It started even before birth. And again, we usually look to the carotid intima media thickness as a surrogate marker for coronary artery event. And the more thick carotid intima media thickness, then the more likely this patient is at risk to develop a cardiac event. And there was a clear association that with the more LDL level, then the more a carotid intima media thickness. And this will put the patient at even higher risk. So again, from Douglas Hart study, childhood measurement of LDL and BMI predict carotid intima media thickness in young adult. Okay. So cardiovascular risk in young Finn study, that the risk profile assessed in 12 to 18 years old predict adult common carotid artery intima media thickness independent of other risk factor. Suggested that exposure to cardiovascular cardiovascular risk in youth early in life may induce changes in the arteries and contribute to development of atherosclerosis. So the rationale, why we should do screening in children. Okay, I'd like to remove this one. Rationale for retiring 1998 ABB policy. When we look to the American Academy for Pediatric Policy and the recommendation regarding screening in children, it is evolving, okay? And because of the current epidemic of childhood obesity and development of risk factor early on life, like hypertension, diabetes, liver disorder, this has changed or mandate change in the current recommendation. And also study have clearly demonstrated that atherosclerosis process began in childhood. So this is number two. The third one is, before there was no approved statin in children, but now there are some intervention which is approved from the age of 8 years. So all this mandate change into the perspective. Okay. So should we screen or we should not screen children for dyslipidemia? There are two schools. So those with screen, they said that the identification of to identify those with familial hypercholesterolemia, which is quite a prevalent condition. Also to identify children with component of metabolic syndrome in effort to highlight and prevent the progression of the disease. And those who are against the screening, that there is no strong, they said there is no strong guidelines when and how to treat, okay? There is moderate dyslipidemia, may be persistent to adulthood with no significant risk factor. Also, before there was no approved statin. Also, they said the screening may put the child and his parent at significant risk and emotional disturbance. And also, it is, if we screen or implement screening at national level, this will have a significant impact on the budget. So this is the evolution of pediatric guidelines for screening of dyslipidemia. From 1992, there was a population approach for targeted screening with family history. Then in 1998, they added risk factor. Then in 2008, risk condition. And lately in 2011, they suggest screening at the 2 age group. So the screening or universal screening is recommended between the age of 9 to 11, then another screening between 17 and 21. And this, I find it very interesting to implement it in our country. If we implement national screening program, and I really look forward to maybe take it to you as organizing committee to think about it, screening the children with dyslipidemia, especially like in central region of the kingdom, then you may generalize the idea. Whenever we have dyslipidemia, we have again to think about the spectrum. Is this monogenic causes of dyslipidemia, or this is polygenic? Is this primary or this is secondary? when we say the primary dyslipidemia, that means there is a genetic cause for increased lipid or abnormal lipid profile, like familial hypercholesterolemia, familial hypertriglyceridemia. However, if we think about secondary cause of dyslipidemia, which is really must be looked at and rule it before doing anything, like hypothyroidism, diabetes, and liver or kidney disease. And there are certain criteria depending on the BMI and lipid profile. So when we speak about diabetic children, the pathophysiology of diabetic dyslipidemia mainly focus into 4 category: increased hypertriglyceridemia, increase in the LDL production, and from increased production of small dense lipoprotein LDL particle and low HDL. So if you can see this graph may be a little bit complicated, but if you take it and make things simplify, the progression from pre-diabetes to diabetes put the patient at increased insulin resistant state, then development of hyperglycemia. With time, this leads to more formation of trauma formation and development of cardiac event. Major determinant of this is increased VLDL secretion and decreased clearance and decrease VLDL catabolism, and decrease also other atherogenic lipoprotein like small dense LDL. In case of hyperglycemia, there will be increase in the VLDL secretion, increase small dense lipoprotein, and decrease in the HDL. This graph is a little bit lengthy, but I will try to summarize it. What insulin do, and if the patient compared to the diabetic when there is insulin deficiency. And if there is enough insulin, there will be decrease in hepatic synthesis lipase, and there is a decrease in the LDL receptor upregulation. However, in the diabetic, there will be a negative impact on this, and also negative impact in lipoprotein lipase, which lead to increased chylomicron production and decrease clearance, which leads subsequently to increase VLDL, intermediate LDL, and small density lipoprotein. So it is very complex process, which end product is increase atherogenic protein, lipoprotein, and put the patient at risk. Okay. And key changes in lipoprotein metabolism in type 2 diabetic, when it comes to chylomicron, there will be increased production and decreased catabolism. And also in the VLDL, the same, increase the production and decrease catabolism, and LDL also decrease catabolism, and HDL increase catabolism. Dyslipidemia in young patients with type 1 diabetes mellitus, it was evident that from this study, high LDL was found in 44%, which is quite high in type 1 diabetic in children. And this finding or certain risk factor, for example, the age, the older children more likely to have dyslipidemia. Also, the obese or the higher BMI, more likely to have more dyslipidemia. And also the worse diabetic control, the higher A1C associated with increased LDL level. So again, this was influence of hemoglobin A1C and BMI in lipid trajectory in youth, young adult with type 1 diabetes, basically repeating the same finding that the patient, whenever he has poor diabetic control, more body weight, then his LDL level will be higher. Spectrum, and this is very nice study about children and adolescents with type 1 diabetes done on 27,000 children, measuring the spectrum and prevalence of atherogenic risk factor in type 1 diabetic children. And basically what they are observed, they have observed the same finding. The longer duration, the worse diabetic control associated with more atherogenic lipoprotein. Okay, so now I can summarize all what I have said into 3 points. Atherogenic is prevalent in type 1 diabetic children. There is evidence that early intervention is better. There is evidence that atherosclerosis is longitudinal process. It starts from early life. So what is the recommendation? Is there enough recommendation to start looking for LDL and to start to normalize this risk factor? So I will present major clinical guidelines, starting with the SPAD. So the SPAD from its recommendation in 2018, microvascular and macrovascular complication in children and adolescents. They recommend screening for dyslipidemia should be performed soon after diagnosis in children with type 1 diabetes from the age 11. So they suggested starting from the age 11. Okay, and they defined high LDL cholesterol more than 2.6 millimole, which is 100 milligram per deciliter. Okay, and they recommend again that LDL cholesterol, if it is more than 2.6 but less than 3.4, start with diet and lifestyle intervention. If it is more than 3.4, then they recommend statin. So they are recommending from the age of 11, okay, and to start statin if the LDL more than 3.4. So what about ADA? So type 1 diabetes and children and adolescents, a positive statement from the American Diabetic Association. What they said, obtain fasting lipid profile in children from 10 years, okay? And if LDL cholesterol value are within the acceptable risk, less than 2.6, a lipid profile should be repeated every 3 to 5 years. Abnormal lipid profile, if there is abnormal lipid profile, then effort should be done to normalize or improve hemoglobin A1C. Okay. And if LDL continue to be more than 4.1, sorry, LDL more than 3.4 and 1 or more cardiovascular risk factor, then they recommend starting statin, and the target goal is 2.6. So in ADA, they recommend starting from the age of 10 years with a stepwise approach. And if LDL continue to be more than 2.6, then start of statin. What about the Canadian guidelines? So in for type 1 children, so they children with type 1 who are less than 12 of age should be screened for dyslipidemia if there is another risk factor. For example, if they are obese or there is family history of dyslipidemia. Once dyslipidemia is diagnosed in children with type 1 diabetes, the dyslipidemia should be monitored regularly and effort should be made to improve metabolic control and promote healthy behavior, while it can be treated effectively with statin. Okay. And so what we can observe from the guidelines that there is no evidence-based enough evidence-based study to recommend when and how to screen for children. All consensus and the guidelines varies between the age from 8, 11, and 12 years. We are all aware about the importance of stepwise approach in treating children with dyslipidemia, starting with the lifestyle modification, which is very important. We need to keep our diabetic children healthy. We need to let them enjoy their life. We need to let them engage in the daily activity and daily exercise. And also, I found such diabetic day is really golden opportunity for them to engage in the community. Again, since we are dealing with children, we need to look for growth. Growth is very important. Poor diabetic control may lead to suboptimal growth, and there are certain syndromes associated with really growth retardation and growth failure, such as Moriak syndrome, due to poor control diabetes. So we need to provide them with adequate nutrition that allow them to grow. At the same time, this diet should be balanced to prevent hyperglycemia and worsening diabetes control. Dyslipidemia is an issue with diabetic children, and but statin has been approved and for children more than 8 years, and it is in the available if the patient need. We need really to look for LDL as major risk factor in diabetic children and change our practice. Let me ask the audience now, how many of you prescribe statin for children with dyslipidemia? Yeah, we have two, which is good. I mean, this is great that we are aware about the presence of this problem and the importance of early intervention. With this, I would like to conclude my talk, and thank you very much.
Thank you very much, Dr. Mohammed, for this nice talk and to bring to us very important information about managing dyslipidemia in children. And I hope more attention will be given to our kids with dyslipidemia. We will leave questions to the end of the session. And again, I remind the audience to write their questions in the questions and answer box. Our last talk will be about the management of acute emergencies in type 1 diabetes from the occasional point of view. And the speaker will be Dr. Iman Al-Aqil. Ms. Iman Al-Aqil, she is the senior She is a senior certified diabetes and pump educator and coordinator of diabetes care program at King Abdulaziz Medical City, National Guard in Jeddah. Welcome, Ms. Iman. The floor is yours.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين نبينا محمد وعلى آله وصحبه أجمعين. Good afternoon, ladies and gentlemen. In the beginning, I would like to thank the organized and scientific committee to invite me for this conference. A special thanks to Dr. Mohammed Al-Mutlaq. My presentation today about management of acute emergency. What is acute emergency? It is hypoglycemia and sick days management. Am I first clear?
Go ahead, yes, very clear.
Okay. What is hypoglycemia? Hypoglycemia for non-diabetic patients if the glucose value below 50 milligram. But for diabetic patients, if the blood sugar level it's below 70 milligram, which is 3.9 millimole. Mild hypoglycemia usually can be managed by the patient him or herself. But the severe hypoglycemia, of course, need assistance or hospital visits. We have 3 grading of hypoglycemia. Grade 1, it's the mild of hypoglycemia. This is when the child or adolescent with diabetes is able to detect or treat hypoglycemia by him or herself. Grade 2 or moderate hypoglycemia, when someone else has to go to the aid of the child or adolescents with diabetes. But treatment usually it's orally. Grade 3, it is the severe hypoglycemia, when the child is become unconscious or coma, and the patient cannot take anything orally, of course need the glucagon injection or IV glucose in the hospital. What happens if hypoglycemia with the counter-regulatory hormone response? If non-diabetic patient, of course, if there is hypoglycemia, insulin will be decreased and glucagon and counter-regulatory hormone will be increased. But for the pediatric or type 1 diabetes, if there is hypoglycemia, no decreased insulin, no glucagon, only counter-regulatory hormone. For type 2 diabetes, if the hypoglycemia happen, insulin decrease, glucagon and other counter-regulatory hormone will be increased. What is the clinical classification for hypoglycemia? Severe hypoglycemia need or requiring assistance. There is a documented symptomatic hypoglycemia. It means symptoms, sign and symptom plus plasma glucose below or equal 70 milligram. Asymptomatic hypoglycemia or unawareness, there is no typical symptom, but plasma glucose, it is below 70 milligram. Unawareness, it means something is dangerous and should be stopped in this point. Probable symptomatic hypoglycemia, typical symptom, but without plasma glucose determination. What is the relative hypoglycemia? It is a typical symptom, but plasma glucose level, it is more than 70 milligram. This is what we call pseudo-hypoglycemia. This happens usually with the patient if get frequent high blood glucose level. This is the sign and symptom of hypoglycemia: mood changes, sweating, headache, dizziness, blurred vision, palpitation. Of course, we divided the symptom of hypoglycemia to autonomic and neuro. Usually autonomic, it is anxiety, palpitation, sweating, tingling, and hypoglycemia and awareness. But the neuro, irritability, drowsiness, dizziness, blurred vision, confusion, and coma. This is the sign and symptom of hypoglycemia: blood glucose value below 70, and the other sign, the one I mentioned just now. Hypoglycemia sign and symptom for neuro, usually plasma glucose below 50 plus sign and symptom of cognitive impairment, focal neurological, lack of coordination, change in personality, and then seizure. Severe and prolonged hypoglycemia get to coma and irreversible brain injury. Hypoglycemia, why does it matter? The major limiting factor for achieving strict control in diabetes patients still is unexpected price for adequate control. Bad impact on quality of life, satisfaction, compliance for diet or treatment, and achieving proper targets. Usually distributing sign and symptom: anxiety, embarrassment, risk of accidents, limitation of performance, rebound, reaction, and weight gain. Hypoglycemia is common in type 1 diabetes more than type 2, and the patient usually on the tight control or intensive diabetes control. Also dependent on the age, like elderly, and duration of disease. This slide just to be summarized of the hypoglycemia, the causes of hypoglycemia, how to manage hypoglycemia. Setting of hypoglycemia: identification of the precipitating factor is important to prevent future events. Hypoglycemia, it's common with diabetes who are treated with insulin versus oral hypoglycemia agents, and very unlikely with lifestyle changes only or using alone medication like metformin or the others. Cause of hypoglycemia: first, food intake. Maybe the patient skipped or delayed meals, vomiting after meal, or medication intake, mismatching wrong dose or too high a dose of medication for the amount of food and too little carbohydrates. Cause of hypoglycemia: unplanned or excessive exercise without snacks or treatment adjustment, excessive insulin or oral hypoglycemic agent doses, sometimes organ failure, medication, alcohol use also causes of hypoglycemia. Identification of the precipitating factor is important to prevent future events. Hypoglycemia and awareness. What causes hypoglycemia and awareness? And this is dangerous hypoglycemia for diabetic patient. This is what we called dead in the bed. Loss of the ability to detect a low blood sugar, and patient need to do frequent monitoring of blood glucose. It may not be a permanent condition, managed by easing the strict control for 2 to 3 weeks or more. As you know, we have something is partial remission or honeymoon phase. Usually in approximately 60 to 80% of children and adolescents decrease insulin requirement following initiation of treatment. Most studies define partial remission phase as that when the patient require less than 0.4 or 0.5 unit of insulin per kg per weight daily, and hemoglobin A1C below 7%. The partial remission phase comes with days or week of the start of insulin therapy and may last for week to months. Frequent hypoglycemia attack happen in this period. How to manage hypoglycemia according to the severity of hypoglycemia, if mild or moderate and severe. We need the prevention and education to manage hypoglycemia. Patient education and empowerment is very important. Frequent self-monitoring of blood glucose, flexible and rational insulin and other drug regimen, individualized glycemic goals, and professional guidance and support for patient and family. Self-monitoring of blood glucose, this is the prevention, and keeping some sugar or sweet handy. Teach patient and caregiver medical alert eye identification like card or bracelet, and glucagon emergency kits is very important. Hypoglycemia management: recognize and treat. Recognize sign and symptom if the document measure of blood glucose below 70 by finger stick versus the unconscious patient unable to swallow. Conscious patient, we can manage it by the 15 grams of carbohydrate orally, but unconscious patient either by subcutaneous glucagon at home or IV dextrose in the hospital. This is if the patient get mild or moderate hypoglycemia, will be follow 50 rules. It's 15 grams of simple form of carbohydrate, like 2 or 3 glucose tablets, half cup of any fruit juice, or 1 to 2 teaspoons sugar of honey. This should be followed by snack of carbohydrate food to maintain normoglycemic until the next meal or snack. Insulin and dietary adjustment should be made to prevent further hypoglycemia when happen. This is the 15 rules of hypoglycemia. Check blood sugar, take 15 gram rule or 15 gram of carbohydrate, and then check the blood sugar again after 15 minutes. This is important notes. Many people like the idea of treating hypoglycemia with cake, cookies, brownies, halawat haniya, like this. However, sugar in the form of complex carbohydrate or sugar combined with fat and protein are much too slowly absorbed to be useful in the acute treatment of hypoglycemia. Once acute episode has been treated healthy, long-acting carbohydrate to maintain blood sugar in range should be consumed, like half sandwich is one option. Should be avoid this whole food, it's fat or complex carbohydrate. Severe hypoglycemia, this is nothing should be given by mouth because the airway should be checked. The person should be placed on the recovery position to prevent aspiration of material into lungs and emergency service. In this case, the patient need to be given the glucagon injection subcutaneous at home. The dose of glucagon for diabetic patient is depend the weight. If below 25 kg, give 0.5 milligram. If more 25 kilogram, you give it a whole ampoule or 1 milligram. If no response within 10 minutes, check blood glucose. If it's still low, repeat once. Follow up with carbohydrate food and frequent monitoring. This is the glucagon kits for treatment of hypoglycemia. All diabetic patients, especially pediatric, has 2 glucagon injection, one in the home and one at school. According ADA, hypoglycemia say glucagon prescribed for all patients with increased risk of severe hypoglycemia and keep it handy. Make sure about proper storage, refrigerator, no direct light, and expiration date. Caregiver or family member, not limited only for health or care professional, should be instructed on its proper mixing and administer immediately. Of course, glucagon can cause vomiting, a risk of aspiration when unconscious. Keep patient on the recovery position. Hypoglycemia and awareness or one or more episode of hypoglycemia need re-evaluation of treatment and regimen. And try to raise the glycemic control. Hypoglycemia management address underlying and cause intervention to prevent recurrence. And should be check the diet, medication, safe activities, and precaution ID and occupied carbohydrate and glucagon on handy. Education, it is very important. I will summarize hypoglycemia. All episodes of an abnormal low plasma glucose that expose the individual to harm if below 70 milligram occurred in both in type 1 and type 2 patients. Hypoglycemia can occur at any level of glycemic, but the risk increases with more intensive therapy and major limiting factor for intensive diabetes control. Now the risk factor and setting, and be aware of nocturnal exercise induced and awareness forms. Treat and try to prevent recurrence. Educate yourself, your patient, and their family.
2 minutes you have.
Okay, now I will talk about the hyperglycemia. Of course, all cases of recurrent of DKA are preventable. How to prevent? By managing sick days in diabetes. Sick days management, of course, people with diabetes get sick just like any else. Average between 6 now infection per year. 4 main concerns: dehydration, hyperglycemia, ketones, and hypoglycemia. Goals of sick days management: prevention and early treatment of hyper and hypoglycemia, dehydration, ketone, and prevent of DKA. Ketone, it means something dangerous. Must check ketone with any illness. Educate about ketone testing, and DKA is the number of 1 cause of death in children with diabetes and almost completely preventable in probably trained family. What cause of ketone usually? Illness, missed insulin, pump insertion leaking, not enough insulin, or stress on body. How to manage sick days management? Frequent monitoring of blood glucose and urine or blood ketone, monitoring fluid and food intake, adult supervision, don't leave it to child or teenager, and easy contact with the diabetic team, and previous education how to manage it sick days. Sick days usually to insulin adjustment plus urine or blood test for ketone. If check urine for ketone every 4 hours, give extra insulin as rapid acting. And you should be follow the rule of 5, 10, 15. If there is 1 plus for ketone, should be give 5% of total daily insulin dose as extra rapid insulin. If there is 2, 10%. If there is 3, 15%. If 4 plus vomiting, need the patient go to ER, maybe get the DKA. 74% of all death in children with diabetes are associated with DKA. And 62 to 63% related death in children are the result of cerebral edema. Thus, general advice, don't stop insulin, increase blood sugar fluid, frequent small snack, no exercise, check blood glucose and urine for ketone every 4 to 2 hours. My summary, sick days require a bit more work for people, families with diabetes. Illness-related factor like sore throat should be handled by the primary care. Good education, as with all of diabetes management, is the key to handling sick days management. This is our law theme for the World Diabetes Day this year, access to diabetes care. Thank you.
Thank you very much, Ms. Iman, for this comprehensive talk about the education of patients and physicians and healthcare provider regarding management of acute complications of diabetes. Because of the sake of time, we'll take 1 or 2 questions for each speaker. I will start with, we received some questions in the Q&A box. I will start with questions for Dr. Saad Al-Zahrani. I hope he's with us. There is one question regarding a patient with hemoglobin A1C of 6.3. He is on metformin maximum dose, diamicron 60 milligram and Lantus 30 units. And he have Down phenomena. So how to deal with such patient? I think maybe they mean Down or Somogyi effect.
Yes, thank you very much for the question. We know that Down phenomena is hyperglycemia in early morning without being preceded by hypoglycemia, where the Somogyi is hyperglycemia following hypoglycemia, and this is occurring spontaneously. So Down phenomena is one of the most difficult phenomena or hyperglycemia to treat. We know in type 1, for example, if you have a patient with Down phenomena, we immediately shift him to insulin pump because it is one of the indications for insulin pump, and you can deal with the pump during the hyperglycemia, and you can also lower the insulin secretion earlier. So you can adjust the dose. But for type 2, it's really difficult because if you are going to increase the basal, you are going to might induce some hypoglycemia, especially with this gentleman with A1C of 6.3%. So what I would suggest that instead of, for example, Lantus, we might use another long-acting analog, might give benefit. Also, we might work on maximizing his metformin. We know metformin is a treatment for insulin resistance. This might improve the Down phenomenon. I would say, I know that I didn't give you a lot of options, but it's really difficult to be treated. Like in the other way is that we have to document it. I don't know how did the gentleman or the lady who asked the question, how did he document the Down phenomena in this patient? Down phenomena has to be documented using a CGM or at least a Libri. Thank you.
Dr. Saad, about the second line after metformin, this I think a wide question mid the lecture. And
Okay.
I have another question for you also regarding the side effect of oral semaglutide compared to injectable GLP-1 analog. Is it better, less side effect according to them?
The company claimed that it's well tolerated and almost similar to the injectable GLP-1. But still, there is nausea, vomiting, but especially in the first few days after the treatment. But with time, it fades away. It really improves. But tolerable side effects.
Line after metformin. So there is one question from the audience.
So the first line after metformin, we can answer it using the latest ADA, ASD treatment guidelines. It depends on your patient. So if your patients, for example, have cardiovascular problem, you can use those medications that lower the cardiovascular risk, like SGLT2 inhibitors or GLP-1 and receptor agonist. For example, if your patient has concerns about his weight, you will go immediately to the GLP-1 and SGLT2, which is known to reduce the weight. If your patient, for example, has a renal problem, you will go to the medication that lowers renal complications. If the patient, for example, is thin, you can use sulfonylurea in such patients. So it depends on patients, and the treatment is really individualized, as we do have a lot of options now.
Thank you very much, Dr. Saad, for being with us up to the last minute and for the nice presentation and answering the questions. Now, the questions for Dr. Mohammed Al-Dabi'i. Dr. Mohammed, there is a question: when to treat dyslipidemia in children? I think you answered this question already in your presentation, but it's good if you remind.
Thank you very much for this question. Yes, I think the message from my presentation is dyslipidemia is a longitudinal process, starts from early childhood. Okay, and paying attention to this problem, increase awareness, and also looking for this LDL level is very important, especially in high-risk group such as type 1 diabetic children. Okay, so whenever we want to treat abnormal lipid profile, we should look to the patient as a whole. I know our families are reluctant really to start statin in children because this is medication for adults, and it's very difficult to convince them to start it. So try, number one, I will say, look for secondary causes of dyslipidemia, for example, hypothyroidism, which is not uncommon, obesity, sedentary lifestyle. Sometimes the patient will have renal or liver problem. So treat the secondary causes. Try to normalize hemoglobin A1C, and try to improve the weight, healthy lifestyle. If this all failed, then we are obligated. We have no other option to normalize LDL except with the statin.
Thank you, Dr. Mohammed. Yes.
Again, thanks, Dr. Mohammed, for your comprehensive talk about dyslipidemia. Again, as a continuation, if the patient either diabetic or is having primary hyperlipidemia, if he is not responding very well and not getting the target for LDL, from your experience for children, did you use the new medication like BCS9 inhibitors, evolocumab, which is easy to use, one shot, same dose every 2 weeks?
Yeah, evolocumab is a new drugs that is enhanced or keep LDL receptor surviving in the hepatocyte. It decreases the LDL degradation, so it will help in clearing the LDL particle from the serum. So there is an evidence now, and starting from the age of 10 years, you can start PCSK9 inhibitors, and from our experience, it is third line therapy in case of familial hypercholesterolemia. We start with the statin, then if we fail to achieve normal control, we add ezetimibe. If failed, then we add PCSK9 inhibitor. And in pediatric population, we use evolocumab 140 milligram every 2 weeks. It is very well tolerable, and the children, they like it because it is injection every 2 weeks. So rather than daily injection or daily taking the pill. But the problem is the price.
So,
Dr. Mohammed, I would just like to ask you one thing regarding this hyperlipidemia. Thank you so much for your talk. Regarding patients who are less than 8 years, is there any level of cholesterol in which we would advise them to go for plasma pheresis? And the other thing that routinely we are doing this echocardiography whenever we receive a patient of familiar hypercholesterolemia, we are doing echocardiography to rule out any atherosclerotic plaques. Is there any indication to repeat this one, for example, every 6 months or 1 year, or just once you did and then afterward there is no indication?
This is very good question. Number one is what is the level? What is the level? Okay, so it depends on the underlying case, what you are treating. If you are treating case of familial hypercholesterolemia, either homozygous or heterozygous, usually they will have very high level, and we don't like to see level LDL more than 3.5. Okay, regardless, okay, after the age of 2 years. But the problem is limited option because statin is not approved for children less than 2 years. And in case of severe hypercholesterolemia, like if the LDL, like in homozygous state, they will have like LDL very high, like in 15. The only available option that is really can be used is LDL apheresis, which is not, again, not available option for a lot of centers. And another limiting factor, you cannot use it for children less than 25 kg. Okay, so we start with lifestyle modification, start them with a statin off label, off label because there is no evidence, but we are dealing with very high risk situation that which mandate that we need to explain to the family that this is really high risk condition, and we are using this medicine off label. So we start them statin, we optimize the dose. If there is no response, we add ezetimibe. If there is no response, we add PCSK9 if it is more than 10 years. For younger children, more than 25 kg with homozygous FH, usually we start with apheresis. Okay.
How to deal with relative hypoglycemia in practice or pseudo hypoglycemia? Patient usually coming to the clinics telling when we blood sugar reaching 150, we feel symptoms of hypoglycemia. And what about use of date, tamur, in management of hypoglycemia? Is it recommended? And it is very common we are seeing in practice.
Thank you. For relative hypoglycemia, it is pseudo hypoglycemia, usually treated gradually as a hypoglycemia till to maintain the blood sugar level within the normoglycemic. And hemoglobin A1C will be reduced gradually till will be maintained in the not dramatically, should be gradually reduces the hemoglobin A1C till to maintain to the 7 milligram. And they can use it like the freestyle Libri to check the blood sugar frequently. What's the other question? Sorry.
Management of hypoglycemia with date.
Usually we can use it, but it's better uses with like juice or something simple. Sugar is quickly. Sometimes they take time to absorb, but we can use it. Date, honey, gum, and 3 dates of 15 grams.
Thank you very much. Because of time, maybe we have also a presentation from the company, satellite presentation from the company. I would like to thank all our speakers, especially for this session, Dr. Mohammed Al-Muhaithil, Dr. Mohammed Al-Dibai, and Dr. Saad Al-Zahrani and Ms. Iman for their nice talk and updated information. And I would like to extend the thanks also for all the participants here and virtually. We have more than 2,000 people staying with us till the last moment of this conference. And now, Dr. Sultan, I think we will start the satellite from the company presentation.
السلام عليكم.
عليكم السلام ورحمة الله. You can share your screen and start the presentation.
سكرين واضحة؟
Yes, you can start. Just put full screen. Thank you.
Assalamu alaikum everyone. My name is Amira Sharaf. I am a medical representative of Lilly Company. And I will talk today, inshallah, about the once weekly dulaglutide tolericity. So patients, when they first diagnosed with type 2 diabetes, or they struggling to achieve the HbA1c, they feel overwhelmed to the new changes, the whole lifestyle modification they have to do, and all of that. So usually the patients in this study, the patients who taking the basal insulin, they fail to achieve the HbA1c less than 7% by 3 of 4 patients. So that's why the new guideline suggests that to take GLB receptor agonist with proven cardiovascular benefits strictly after the metformin and lifestyle modification. So in this patient, we can see the HbA1c between 7.5% to 10%. The patient is overweight. He hasn't had a cardiovascular event, but he has a cardiovascular risk factor. And as most of the population who had cardiovascular risk in the high blood pressure, obesity, smoking, and etc. So this patient is having discouraged and the lack of the motivation to start a medication and stuck with it for lifetime. So for this patient, how we can impact for his life. So the patients we have in type 2 diabetes, most of the population, they have a cardiovascular risk. So preferably to take medication to control that diabetes with like beyond hyperglycemic management, but also with another benefits for these patients. The patients starting diagnosed with type 2 diabetes from 8 to 10 years duration, they may develop cardiovascular event. So for type 2 diabetes itself, to making the cardiovascular risk higher, and the management for diabetes should be beyond just hyperglycemic control. And that's why Trulicity give more than hyperglycemic efficacy. It's having powerful HbA1c reduction across all doses and proven cardiovascular benefits in both primary and secondary prevention. So these patients not only having achieving the goal of HbA1c, but also having both primary and secondary cardiovascular prevention, the simple delivery of the pen, and sustainability effect. So how powerful and sustained efficacy? For these patients, after taking the first dose of Trulicity, they don't have to titrate the dose. The dose will immediately having effect. The patients will see in the home with a small device that the reading will be reduced in just 48 hours. So because of that, the patients prefer, like if they see the results in the home after only just 2 days, they will, and the simplicity of the pen, it's very simple to use, they will prefer to stuck with this medication. So in the PREFER study that showed that patients trying Trulicity and semaglutide, they prefer Trulicity by 84%. So why they prefer it? First, because it's very easy to use the pen. You only uncap the pen. You don't need to attach a needle. The needle is already there. It's hidden needle, so the patients scaring from the needles, or they like intimidated by taking the pens and the injections, and so So it's hidden, so it's very easy to use. The place and inject site at unlock, so there is no dose adjustment. The pen is already pre-filled injectable. So only unlock the pen, place it, and press and hold. So the easy step to take the pen to touch the skin and you insert the injection, there is no need to do it. You just have to place the pen and press and hold until you hear the click, and that's it. So for the patients, it's when they see the pen is very easy to use, the adherence to the pen will be more. So patients with Turlisty, they have 40% more to adhere to it in versus of semaglutide, and that's because of the simplicity of the pen. So the award studies showed that all of the award study, the patients achieved the HbA1c less than 7. So the Turlisty is very effective, and also the sustained effects is there as well there, because there's another study shows that Turlisty will be, the effect will be sustained until 2 years. So over the 2 years, the patients will be when they adhere to the medication, achieving the HbA1c will be sustained over 104 weeks, and so if the achieving HbA1c is a short goal, so what about the long goal for the patients? So the cardiovascular benefits worth considering. And why? Because people with type 2 diabetes are 2 to 4 more time likely to develop cardiovascular disease compared to someone without type 2 diabetes. So Turlisty have a primary cardiovascular prevention and secondary cardiovascular prevention. And that showed in the Rewind study. The Rewind study was a study testing the cardiovascular benefits for GLP dulaglutide, and the other study was on the GLP, but we can see here the number of patients in the Rewind study was higher. It's 9,900 patients, and the selection of population very unique because they select 46% of the patients female and the other was male, and that mimic the people you see in your clinic, because there is real world data in this. So the prior cardiovascular disease in these patients only 31%, and the HbA1c is 7.3. We can see here it's 7.3. It's almost control, and that's why the Rewind was testing the dulaglutide, because the effects happen from protecting, from having the cardiovascular benefits. It's from the molecule itself, not because the HbA1c reduced, and that's why the cardiovascular risk reduced. No, it's because the dulaglutide itself have the primary and secondary cardiovascular prevention because of the dulaglutide molecule. The median follow-up was 5 to 4 years. And the outcome was the MACE reduced by 12%. So 12% is very good percent, and you will prevent the patient from having primary and secondary before they have the events. And that's why you protect the patients in the long term. So Turlisty is the only one from the others that have the both primary and secondary. So you don't have to wait until the events happen and then you protect it. No, you will protect it. You will protect the patients before even having the first one. So after the Rewind study, the American and European Associated Society said that the dulaglutide itself, it's the only one having primary and secondary cardiovascular prevention along with the GLP receptor agonists. So add-on benefits of Turlisty, the weight loss. So the patients will have a weight loss in 3.9 kgs comparing to the insulin glargine that will make the patient have a weight gain by 3.7 kg. But in the real world data, the reducing of the weight was 6.4 kg. And you can see in your clinic that maybe the number of the kg loss may be more than 6. Some of the patients will reach 10 and some of them 15 because of the patient variety and patient lifestyle. So as well as the efficacy, the weight loss will be sustained over 2 years. So from the first administration of the dose and the patients adherent to the medication, the weight loss will be sustained over time. So as conclusion, the Trulicity have powerful HbA1c reduction, primary and secondary prevention of cardiovascular events, and Trulicity, the patients can take it any time of the day. The effect will be starting from the first dose. There is no need to titrate. There is the pen is very unique. There is a pre-attached needle and there is no need to dose adjustments. The low incidence of hypoglycemia, once weekly medication, and low discontinuation rate because of the GI events and the potential weight loss. So thank you. Please feel free if you have any question to ask.
Thank you, Ms. Samira, for your nice presentation. If anyone has questions,
Yes, excuse me.
Dr. Al-Mutlaq.
Thanks for a nice presentation. My question for Trulicity, what is the what is the age, lower age to be given?
There is data now to consider taking Trulicity with the pediatrics. It's maybe we will wait for the guidelines to ensure this, but there is upcoming steps to use Trulicity in pediatric patients.
Yes, any age limit? Is it from the age of 18 or so on, or we need to revise it?
Not the data maybe before 18, but I'm not sure if I can say this now because there will be studies in that and updating maybe in the guideline also or so. So I can't say if there is for less than 18s, but for 18s and more, it's considered adult, so they can't.
Thank you, Ms. Samira, for your presentation. And thank you for the more than 900 participants who stay till this time. Thank you all for joining us this conference. Thank you.